Inguinal hernia, you need to have very good exposure, and the position is starting off is standing. Ask him to remove the pants and roll up the shirt so that you really expose the whole entire two groin orifices at the scrotum. So you start by saying what you see, inspection, right? So inspection, there is a groin lump located in the inguinal region. It does or does not extend into the scrotum. So that's the first key thing you say, because if it extends into the scrotum, you're indirectly telling the examiner that it's most likely an indirect hernia. Okay? Look for scars. Look for skin changes. The scars of an open hernia is very different from a laparoscopic hernia. I'm just gonna. So laparoscopic hernia scars are three scars from here, here, and here. All right. There are some variations, but generally they're all in the midline. So look out for the inguinal, the laparoscopic scar. The open scars are more common. They're a straight line on either side, lah. Okay. Ask the patient to cough now. Can you cough for me, sir? Cough. So this is the visible cough impulse. You want to say, is it present or absent? That's it. Then move on. Alright, so whether or not there's testicular swelling on both sides. Now you need to palpate. So when you palpate, you ask, is there any pain? No pain, move on. So we're doing a right side hernia. You stand on the patient's side. You always stand on the side. My recommendation, stand always on the side of the hernia, because it's easier. If it's on the right side, stand on the right side so you can examine. If it's on the left, you're going to use your left hand. And it just looks, if it's bilateral, where do you stand? You don't stand in front and do like that. It's very awkward, alright? So generally, if it's bilateral, I stand still at the side of the patient and ask him to cough, alright? Don't stand in front, it's just presentation now. So presentation is very important when you go for your MBBS. Alright, so ask him to cough, palpable cough impulse, alright? Then now you quickly feel the lump and describe it. You don't need to describe all the characteristics of a lump and bump, like side, shape, all that. You just need to go through very quickly. Is it soft? You see SECT there, that's generally my own acronym. Surface, edge, consistency, tenderness. This is all I describe for hernia. So it's soft, it is regular edge, and it's, the surface is smooth, edge is regular, soft in consistency, is non-tender. Okay, in the exams, generally you'll get a non-tender one. Okay, the next step is you got to feel the testes and feel whether it is separate from the mass. Right? The key thing you need to say, it's separate from the mass is separate from the testes. Because if it's not, then you're indicating it could be a testicular mass. Then can or cannot get above the mass. So hernias, generally you can get above it. You cannot get above it. Testicular mass, you can get above it. Alright? Next, feel the other side. Alright? And then do the same. Okay, the next step is lie the patient down. So you need to lie down. Okay, so when you're lying the patient down, generally, personally, I straight away landmark the patient. Alright? So ASIS, pubic tubercle, midpoint, 2 finger breaths up. What are we locating? We're locating the deep inguinal ring. Alright? So once I've located it, you're already telling the examiner this is my deep inguinal ring. And sir, can you reduce it yourself? You try to reduce. You already roughly know where the deep inguinal ring is, but you reduce. So you let the patient try to reduce himself. If he can't, it's very big, you have to reduce it yourself. This is where I see most people fumble, because you don't practice this very often. You need to reduce it. If it's a very large inguinal scrotal mass, your left hand actually stays on your deep ring and helps to funnel the it's very hard to show. I need to, but basically one hand is constant pressure. The left hand actually funnels your contents into your deep ring. If I see a lot of people just trying to whack like that, there's no way it's going to go in, because it's all being stuck at your deep ring. You have to help to funnel it in. Okay, that's a key tip, right? Once it's in, you're going to ask the patient to stand up. Okay, maybe you turn to the side. Okay, your hand is on you've already reduced it and you ask it to stand up. You turn around, okay. So turn around your face. Where's my 2 fingers? Actually, all you need is 2 fingers. It has to be exactly on the deep ring where you have located. Okay, so when you stand up and if you see a hernia come out, there's only 2 possibilities. One, it is a direct hernia, okay? or your hand was in the wrong position. It was indirect, but it's already starting to come out. Okay, so you got to make sure that your hand is really, or your fingers are spot on the deep ring. And then most times it is contained, it's well contained there. Then you ask him to cough. So it should not come out, alright? If you have done it properly, if you have reduced the indirect properly, if it comes out, you can say it's a direct. Then you release and ask him to cough again. And then this is where I explain whether it goes into the, if it's an indirect hernia, it should move in an inferior medial direction into your scrotum. So I'll say it reappears in an inferior medial direction into your scrotum. Versus if it was a direct and you have reduced the direct, it should just appear anteriorly. Anteriorly and a little bit of inferior, but it shouldn't go into your scrotum if it was truly a direct hernia. Okay? Can. I think you use it now. Then you finish off by auscultating the mass and examining the abdomen. And then your wish list. Okay, so all GS shock cases, you don't need to do the entire steps. It's not like a medical shock case. So GS shock case is quite chop. All this right we have done, it should be done in like about 2 minutes, roughly. So you say, cannot. One of the key points, I'll pause here. Okay, so one of the key tricks about GS shock case is that you only have about 7 to 8 minutes. So the longer you take to examine, if I take 5 minutes to examine, do a perfect examination, you only have 3 minutes left for your question. So a lot of students take pretty long in their examination, but you give yourself very short runway for your question. So by the time I ask you 1 or 2 questions, the bell is going to ring. The guy who has examined for 2 to 3 minutes, he has 5 minutes runway for questioning. That student usually goes further in the shock case, and he reaches management, and then they score more overall marks. The global marks, don't forget, you're scored for each component. Clinical findings, investigations, management, overall performance. So you got to score for all, got to go further. So this one, practice, you should be able to do this very fast. The hardest step is actually the reduction. The rest is all pretty straightforward. Okay, wish list, I'll say I'd like to do a respiratory examination looking for chronic symptoms of chronic respiratory disease, COPD, asthma, like wheezing. Abdominal examination, you're looking for raised intra-abdominal pressure. So palpable bladder, abdominal distension, abdominal masses, you have to mention. Now, this part about abdominal distension is that you are actually looking for, it's a two-way thing. It's a chicken and egg thing. You're looking for things which would lead to the hernia. So if I have an IO from a rectal cancer, you will cause raised intra-abdominal pressure and it could present with a hernia. But you're not going to get this kind of case in exams. Most often, it's just how you mention it. So either you're looking for a cause for the hernia, or the hernia itself could be the cause of the IO, which is a complication of the hernia. So it's just how you articulate it. I'm looking for things which could lead to raised intra-abdominal pressure, which may precipitate the hernia, or a complication as a result of the hernia, which is an intestinal obstruction. Okay? You do a PR to look for rectal masses, prostate, as well as impacted stools, right? Constipation, because these are precipitating factors. And then of course you just say take a social history from the patient. This is just how you wrap up. Okay, let's move on. Okay, we got a rush, we got quite a few. So this is generally the one on the left is the one you're going to get in the exams, where it's pretty reducible, very small. This one is a bilateral. Okay, this one is more, what do you call that? It presents in the emergency. Okay, let's talk about the first one. We have already gone through the steps. All you need to do is make sure that this is not what? A differential. One possible differential for this is some audience participation. Differential. Huh? Excellent. So actually, you just need to make sure it's not lymph nodes. What other possible differentials are there for inguinal lymph node? Inguinal hernia. If you see this exam, ask you for differentials. Lymph nodes? Anyone else? Saphenopharynx, but you're going to get bilateral saphenopharynx? No, unlikely, right? And saphenopharynx won't be so big. Usually it's actually much lower. This is actually a deep ring level. Where's your saphenopharynx? Yes, so it's below inguinal ligament, right? It has to come from a SFJ, which is around here. So this is pretty high up, but yes, reasonable differential. Okay, now my point in this case is that, okay, let's talk about investigation since we're on this picture. I always talk about investigation. How will you investigate this guy? Okay. Jeremy, come. How do we investigate this guy? The story is that he's a 50-year-old gentleman, comes into the clinic, walks into the clinic, has this for about 2 months, totally painless. He said can push back one.
Okay, so I want to do a full history and physical exam.
Okay, examine. You think it's an inguinal hernia.
So then I want to, if I'm not wrong, inguinal hernias are clinical diagnosis.
Excellent. Okay, that's all I want to hear.
Yeah.
It is a clinical diagnosis. I don't think I need any more further investigations. However, if I can't diagnose this clinically now, this is extremely hard. It can't reduce. It feels like a lymph node. What are you going to do?
I want to do some investigations. I can divide my investigations bedside plus imaging.
Okay, actually, bloods, yes, plus minus, but what imaging you want to do? Excellent. Okay, ultrasound, right? You realize that I'm trying to just hear one answer only. That's how a short case is. You don't need to talk in it's very chop. So it's yes or no kind of answer. I just want to hear ultrasound. I'm going to do an ultrasound for this because I want to look for diagnosis which is not inguinal hernia. Otherwise, it's a clinical diagnosis. I don't need to do any further investigation. If you're going to list for op, yes, you do pre-op investigations. That one is separate. But this is diagnostic investigations. So rightly, I just want to hear ultrasound. You score the mark already. Okay? So just remember, in short case, it's like that. Alright, just straight to the point, get to the answer, move on to the next question. It's a little bit different from long case. Long case, you have a bit more time to elaborate. They want to see your understanding of the thing. Alright, now this fella, 60-year-old chap, presents to the A&E with 5 days history of vomiting, worsening abdominal distension and pain, couldn't pass motion for 3 days. No flatus also. Comes in, a bit tachycardic. Okay, next better player. The guy behind? What's your name?
Zeno.
Huh?
Zeno.
How? How you want to investigate him? Sorry to stress you all. Never mind lah. Just try your best.
First all the actual patient is stable.
Ensure patient stable. Okay, all the stable stuff, right? Move on. Okay, what else you want to do? That one everyone's going to say ensure ABC, right? You're not scoring any marks.
Yeah.
What you want to do? What are you worried about?
So I'm worried about incarceration or strangulation.
Good. So you worried that this one is more complicated. There's a complication from this. Alright, so what investigations are you going to do? It's a little bit different from the guy on the left. What investigations will you do?
I think for imaging I can consider just performing ultrasound.
Ultrasound.
I can also consider performing an abdominal X-ray.
Excellent. AXR. Okay, bloods, look for infection, look for renal panel, all that. That's all standard spiel. But with regards to this case, I want to hear an AXR being done as a first imaging investigation. To look for?
To look for any intestinal obstruction.
Good. Dilated bowel loops. To suggest intestinal obstruction. Okay, very good. Air fluid levels, the standard bowel loops. AXR. I'll show you some pictures later, not to worry. Any other investigations? Any other imaging you want to do with the question?
Maybe I'll consider doing an electric X-ray to look out for motor.
Okay, plus minus. With regards to this case, anyone want to do a CT-AP? CT scan? Anyone in this room want to do a CT scan? Come on, someone just resisted. Huh? Yes. You want to do a CT scan? Why?
I think it will help to delineate the anatomy if you're going to go for op later.
So delineate anatomy if you want to go for op. Reasonable. I would do a CT scan, but not really for that reason. You haven't hit the money yet. Let's see who can give me the 9 and 10 mark. You already passed lah, you reached it. But yes, what else? That's a reasonable, I accept it. You look for, to plan your operation. But not really. This guy needs an op. What else? Why would I do a CT scan in this case? bowel ischemia, but will the CT scan make a difference? Clinically, does he need an operation? Yes. Okay, if I tell you AXR got distended bowel loops, this guy needs an operation. So regardless, you're going to fix the problem. It doesn't help you to say yes or no, need an operation. You already know he needs an operation, but how does the CT scan help you? What else does this guy have on the clinical examination? Yeah, what's this? Scars. So, adhesions. Okay, we're getting somewhere. So, adhesion IO. Remember my point about the chicken and egg. So now what's the pathology of this? Everyone thinks, most people will say that, look, repair this because the IO is from here. What if I tell you there was an adhesion band right here, causing the IO? We fix the hernia, wow, push everything back. Actually, wow, open all bowel loops are healthy, push everything back. The kink was here. Have we solved the problem? No. Your transition point wasn't in the here. The transition point was here. Okay, this is a bit higher level thinking, but it's not beyond your. So a CT scan sometimes looks for pathology other than the. So I'm looking for an inciting pathology. What if he had a rectal tumor? Oh, sorry, this descending colon tumor causing IO, causing the hernia. Possible, right? You just lived with it long and long, cough and strain. So look for pathologies other when the history doesn't sound right. I've loss of weight, PR bleeding, constitutional symptoms. Then you want to CT scan this guy. I want to make sure that I go in and repair this and there's nothing else in the abdomen. Because you sometimes repair it just from here. I don't do a laparotomy. Okay, that one is also another part, surgical exploration. Okay, so get the point? CT scan. The other bloods you can potentially do is ABG lactate. Some of us do lah, to look for potential bowel ischemia. Alright, lactate acidosis. But not always. If it's normal, it doesn't mean that you do not have ischemic bowel. Okay? Alright, let's move on. So you roughly need to know the classification of hernias, or rather a little bit of your eponymous hernias. You don't need to know all. I just put it there for general knowledge, but you need to know pantaloon, you need to know Richter at least. Pantaloon means both lah, indirect and direct. Richter, it means one part of it is strangulated but not obstructed. Okay, you Google Richter, you have a picture. I don't have a picture here. Sure. Okay. These are the questions you're generally going to get as a first few marks kind of question. How do you differentiate direct versus indirect anatomically, Hasselbalch's triangle, surface landmarks, boundaries of inguinal canal, contents of spinal cord? These are all anatomy. This is 背书. There's no thinking involved, right? Just remember. So I'm just going to quickly go through. Just as a recap, Hasselbalch's triangle. Oh, actually, I didn't put this. Okay, lateral border of your rectus muscle, inguinal canal, inferior epigastric artery. That's your Hasselbalch. That's where your direct hernia comes out from. Your indirect will come from your deep inguinal ring and follow your inguinal canal down into your spermatic cord, along with your spermatic cord. So just need to know the anatomy, right? Those questions can easily be found, the answers in your textbooks. So I won't, those which are already in the textbooks, I won't go through. I will value add those which need a bit more thinking than talking. Okay, yeah, I mean all this is general stuff. Okay, oh yeah, the other point about superficial inguinal ring. Some examiners ask, where's the landmark for your superficial inguinal ring? Is there a landmark? So there actually isn't a landmark because your superficial inguinal ring actually comes when your fibers of your external oblique decussate, and it can decussate at different areas. That means it splits. It can split at different areas for different people. So your superficial inguinal ring just needs to know that it is above, superior. Oh shucks, way too fast. Sorry, my bad. All you need to say is that it is superior and medial to your pubic tubercle, the location. Superior, medial. That's where your superficial ring actually is. As opposed to inferior and lateral, what are we landmarking? Femoral hernia. Okay? So there are a few ways you say, how do we differentiate femoral from inguinal hernia? You can either use your inguinal ligament, above and below your inguinal ligament. Below is femoral, above is inguinal, or use your pubic tubercle. Above medial is inguinal, below lateral is femoral. Okay, so use pubic tubercle as your landmark or your inguinal canal. Okay, boundaries of inguinal canal. This one is inside textbook also, so just remember, take note, go back and read. Contents: 3 arteries, 3 nerves, 3 others. That's how I remember it. Alright, you just got to mark it. Okay, next. How would you investigate this patient? I briefly touched on this in the previous one. So you got to decide, is it presenting acutely or is he presenting electively? That means in the clinic setting. Because the investigations you do in the clinic is very, very minimal. At the most, an ultrasound or plus minus a CT scan if you think, or even you may want to do a colonoscopy if he has symptoms and signs to suggest that he may have a cancer, colon cancer. That's usually what because majority are guys, are male, I always check the prostate, refer to uro if need be, do offer colonoscopy if he's above 50, he has strong family history, or he has symptoms to suggest that he might have colon cancer, before I ever list them for an operation, because you must make sure that you have treated the precipitating causes. So you got to ask history and all that. Otherwise, the clinic setting, you don't need to do much investigations. But the guy who presents acutely, you got to do a lot of investigations, but mainly EXR, making sure that it's not complicated, from obstruction, strangulation, perforation onwards. Alright, we'll go through the complications in a bit. Okay, I'll just move through the complications at this point. So it's a stepwise process. I think some of y'all who's been in my tutorial have seen this, but I'll just quickly go through from it, right? It starts by being reducible, then becoming incarcerated. So you got to get the terminology right. Incarcerated just means it's irreducible. Okay? However, incarcerated can also be symptomatic or asymptomatic. The guy can live with an incarcerated hernia and be totally pain-free for years. These guys are asymptomatic because the difference is that these guys may not need an op so fast. The guy who's tender, he comes to A&E, wow, very painful, is incarcerated. But you do an AXR, it's not dilated, he has no symptoms, he can still pass motion and all that. These guys are symptomatic incarcerated. You tend to want to operate on them also earlier. It's not urgently, but earlier. Then it becomes obstructed. Okay, when you're obstructed, you're going to get EXR findings. You're going to get symptoms already, vomiting, distension, right? So look for it. The arrow is pointing to what? Anyone? This guy has a left-sided inguinal hernia. Bowel gas. Okay, so this is actually bowel gas. You can actually sometimes, if it's huge inguinal hernia, look at this area where the pubic tubercle is. Right? This is where sometimes you get some bowel gas. This one, wow, you can pick it out on X-ray. You score your knife mark. Okay. Strangulated. Now, what is strangulated? What's the definition of strangulated? Okay. Just means no more blood supply. You're going to get ischemia. You're not necrosis or gangrene yet, but you're going to get ischemia. Strangulated, you still can salvage. It doesn't mean it's unsalvageable. You quickly release it, you sometimes can save it. Okay, now what is this? Wow, such a solid photo. Gangrene or ischemia? Ischemia. Okay, haven't seen ischemia bowel. Okay, this is dead already lah. This bowel is gone case. Cannot save. There are some which you see. Okay, this one you need to do GS, then you'll see the difference. But anyway, once you see this, it's gone. It's GG. You need to cut it off, right? So this guy is very young. This guy is 34 years old. Alright, he came, I remember this case, I did this operation. I mean 3 days of, actually in fact 2 days of pain, very acute. Came in, wow, exquisitely tender, touch really is jumping. Rightly so, we didn't even need to do any investigation. I didn't even need to do an AXR. This guy is clinical. Operated as a P2, I mean within 4 hours, and we found this. And we had to resect it. So we resected it, and we stapled it and pushed it back. Now, I show this picture because how do we repair this? You see the sutures there? So how did we repair this? I mean the defect. I mean we pushed back everything. The defect is closed with just sutures. Do you see any mesh there? No. What is this repair called? Shoulder dice? No, not so. Okay. So this is, okay, just simply put, if you're not sure, you don't need to know the terminology, this is a tension repair. Okay, it's not tension free. That means it's not with a mesh, right? That means I'm using sutures to repair the defect, because that's where we cut open the lateral aspect to take out all the bowel. But this is your spermatic cord here. Okay, I'll come to this later. Just remember this case. Then after that, you can get perforated, you get peritonitis, and oh yes, the question is, when should we operate? Okay, this is a very common question. At what point, at what level should we absolutely must operate on the patient? What do you all think? Strangulation below. Anything strangulated, chop. Anyone else? How about obstructed? If my AXR shows dilated bowel loops, can we wait? Can wait, drip and suck. So, got all the SIPGS already. IO equals drip and suck. That's not true. It doesn't work for hernia because the obstruction is in your hernia sac. You need to operate. Okay, the transition point generally is at the hernia sac. But you drip and suck to make sure it doesn't aspirate. So it's not that it solves the problem. It's not like adhesion IO. Okay, it's a bit different. Okay, so anything below obstruction, absolute indication you need to operate. That means within the night. You cannot wait overnight. Incarcerated, I told you, is it symptomatic or asymptomatic? If it's asymptomatic, I see him in the clinic, do I need to list it straight up and operate overnight? No, you don't need to. If this guy comes into A&E, wow, painful, generally I tend to operate within that admission. Next day I'll operate. It doesn't need to be like overnight, but he needs to get it soon because he can go down the path. You send him home, he comes back with gangrene, you convert a totally elective operation into a resection. You sometimes need laparotomy. The guy I showed you just now is very lucky. We could do it through the groin. If you can't, if it's high up, you need to do a laparotomy. Okay. Oh. Okay. Go back to the questions. Let's go back. Sorry. What are the management options? So we're going on to management questions already. So management can be divided into conservative and surgical. So for conservative, okay, I'm going to move on here. What surgery options, indication of okay, complications, okay, easy. I'm going to move on. I'll just remember the questions. So what are the conservative options? What should you be saying for conservative? Bobby, try.
You treat the underlying cause.
Okay, good. That's what I want here. Treat the precipitating cause. COPD, refer to RESP. BPH, refer to Euro. So treat the underlying cause. Next.
Try and reduce it yourself.
Try and reduce. Then after you reduce, you ask him to put his finger there forever. Walk around. What can he wear? Hernia truss. That's not the picture. Okay. You all know what a hernia truss is? Abdominal truss. Iron underwear. Okay. How many guys I ask you to wear this, you'll wear? You strangulate your other things. So it's very uncomfortable, okay? Hernia truss, very easy to say, but a lot of patients, you ask them to wear this, you say, siao. It's very uncomfortable. You get actually pressure on your orifices because it's tightening the entire, what you want to cover, you're right, you reduce it, what you want to cover is the orifices. You prevent it from coming out from your deep ring. You want to wear it and cover your myopectineal orifice, your deep inguinal, your Hasselbalch's, your inguinal, your deep ring. So it protects it. It doesn't come out. It always stays back. There's no chance for the defect enlarging. That's what a truss does. Yes, we offer it for which kind of patients? Those which absolutely can't tolerate COPD, AF, ischemic heart disease, ESRF. Those very high risk for operation, yes, we can offer. But this works usually when you stand. When you're lying down, you don't need to wear it. Okay, so when you're lying down, there's no pressure. But when he stands, when he strains, you should wear it. Okay, abdominal truss. Surgery. Okay, lifestyle modification. That's the last one. If he goes to the gym a lot, tell him don't. You can't change. But some people, it's their profession. They are hawkers. I've got some patients who are hawkers. They stand long. It's their job. It's their livelihood. So you got to repair. No choice. You got to offer surgery. There's no conservative for these people because you don't want them to get a complication from this. It's even worse. Okay, now surgery. How do we break it up? Either open or laparoscopic. Okay, I'm going to put up this slide. I won't ask too much questions because we waste a lot of time if we. So, like I said, there's a tension-free. These are the keywords in inguinal hernia. Tension-free mesh repair versus tension repair without mesh tissue repair, which is what I did for that gentleman. Now, why did I... Okay, this is even higher. Why did I choose to do a tissue repair? Generally, what do we do nowadays? You shouldn't even mention tissue actually in exams. The standard nowadays is mesh repair, Liechtenstein repair. Why did I do a tissue repair for that guy? This one is 10th mark. Anyone? Bowel ischemia, so? Okay, even if I didn't spill, wow, flawless technique. But you're almost there. You're getting 9.5. So bowel ischemia, once you have bowel ischemia, what wound is it? You have to talk about wound classification. So what wound has it become? Usually when I operate on inguinal hernia, it's class 1 wound. You all know the classes of wound? 1 to 4? Oh, some empty stares. Okay. So that's classification of surgical wounds to get surgical site infection. I don't have a slide on it, but it's inside my other resource. Class 1 wound, absolutely no entry into bowel, or it's like I do a lipoma operation. There's no contamination whatsoever. But once you have ischemia, you convert it to a class 2/3 wound. It's not frank. Once you have frank pus and frank like a perforated divert, it's a class 4. When you convert it to a higher class wound, your risk of surgical site infection is increased. So if you want to put a mesh there, which is a foreign body, there's a chance that you get mesh infection, which is an absolute disaster to operate on. So you should, that's why I did tissue repair. For that reason, tissue repair is not redundant. In certain circumstances, tissue repair still is important. Okay, when you can't put a mesh. You don't need to know the names, Schodis, Bassini. Even if I ask you what's the difference, you're gone. You don't know how to articulate it. So don't, right? Refrain. Unless the examiner, you know any operations, then you show this to impress him. But this is for surgeons, right? If you have ortho, because your examiner, it may be differentiating between ortho, GS, they won't ask you this kind of questions. Okay? Alright. Laparoscopic, okay. You don't need to know TEP, TAPP, you're not going to go there. If you take higher surgical examinations, yes, you need to know. But laparoscopic, what are the indications for lap repair? You need to know this. What are they? Bilateral hernia. Recurrence from what? Open repair. Excellent. So you must quantify. Nowadays, if I start off with lap, nowadays everyone's doing, most of my ops I offer lap. If I recur from a laparoscopic, I repair it open. You repair the opposite because the plane is now, you want to enter a different plane. Your mesh for an open sits in a different plane from your mesh of a laparoscopic. You just need to understand that it's in a different layer. If you understand that, it means your approach should be different. You don't want to enter scarred area. Okay, that's the concept. So recurrence from whatever, or open surgery. And the last one, patient one. Request. So if you come to me with a hernia, you want big scar or you want 3 small scars? So now, which leads me to my next question is, what's the advantage? You come to me in the clinic and you say, what's the advantage of lap versus open if I offer? What's the answer? No difference. Smaller scar. What do you think is the difference between the advantage? Is there a difference in recurrence rates? There shouldn't be, because if there is, I will offer one over the other. Okay, but there is a slight. In the large studies, recurrence rates for open hernia is slightly less, but we're talking about very minute. They're almost equal. Okay, so recurrence is not a factor. So the only advantage of a lap is that there's less pain, obviously. The scar is smaller, you cut less tissue. Less pain and faster return to work. So which patients should we be offering it to? Younger patients and those which want less pain. You don't need to be young, but you got to just show the advantage. But it's much more costly. You use a lot more appliances. Okay. This is the Liechtenstein. We got a mesh. Okay, we better hurry. It's only topic number 1. Okay, so complications of inguinal hernia. Just know that it's general specific. Main things, you get ARU, post-op because of the pain, you get ischemic orchitis if I cut the testicular arteries, you get chronic pain if I tag it to your nerves, ilioinguinal nerve, and you get recurrence in the long run. We're talking about 5-10 year recurrence, not so fast. If you recur straight up, what's the problem? Surgeon's fault. You shouldn't recur immediately within, it usually lasts for at least 5 years, 5 to 10 years. Okay, if you have any recurrence before that, I mean, you consider it recurrence. Okay, Ken, let's move on to femoral hernia. Any questions for inguinal hernia in the room? I don't know if we can take questions from the floor. Yeah, why don't you gather the questions? Just, okay, I think how we're doing it for the rest at home in the Zoom, right? You just can write down, there's a chat board, right? There should be a chat board. Just put up your questions there, we'll answer, we'll have a midpoint. I'll cover a few topics, we have the questions all at the end, at the midpoint. Okay, we do that, if not you interrupt the flow. Okay, femoral hernia, I just want to point out that if you look at the location, right, it's a bit below your inguinal ligament. It is very circumscribed. Femoral hernia, your ring is damn small. It can't be so large, right? So it looks like a lymph node, right? But it's usually very tender. You're not going to, very rarely will you get this in exams because they're usually operated immediately. Okay, femoral hernia is usually an emergency. Very rarely. Boundaries are a little bit different, so go back and read up. We're talking about that orange area. This is where your femoral canal is, right? Sorry, not the orange area, my bad, the yellow area. Orange is lacuna ligament. Just need to know a few questions for this. Contents. And all you need to know is that femoral hernia presents emergently because your canal is very small. It's more rigid and it tends to be strangulated or obstructed. And it happens more often in women, right? Because of the space in that area. Okay, skin lumps. This one I'm going to rush through because it's too easy. Actually don't even need SP. So, look, feel, wish list, right? Size, shape, skin, scars, color, symmetry. Okay, feel. So, I have an acronym because I want to be systematic in what I say. I don't want to say, oh, have I mentioned surface yet? Have I mentioned this yet? You forget. I always go, this is my own. Surface, I mean, it's actually sector, others and reducibility, but surface is what, edge is what, consistency is what, is non-tender. I mean, this is just how I describe every single lump in exams, even to my FRCF. Compressibility and reducibility, you need to know the difference. Some of you may have heard these terms, but actually you know there's a difference in the definition. What's compressible and what's reducible? Reducible means I push a force to reduce it, it comes out with a force. You need a force to make it come out. Whereas compressible, I press it, it comes out it comes back spontaneously. What is compressible? Hernias are reducible. What is compressible when you describe a lump? You're never going to get this in exams, but you need to run. Anyone? Never heard before. What compressible thing? Because it's not inside MedBed. Always jokes, right? Because you never read Norman Brown's. Norman Brown's is the Bible for examination. But so compressible means arterial venous malformations. So there are lesions where it's compressible. You press it, it disappears, but it appears spontaneously. So AVMs, all right. Fluctuation. How do we do the fluctuation test? We need to demonstrate this in an exam. So, the lesion is like this. So I press the lesion and I press the center. I should feel my 2 fingers move apart, and you do it in perpendicular directions. Okay, so that's fluctuation. Fixation, you need to tense the underlying muscle. Transindominate possibility. Okay, assess regional lymph nodes. Assess neurovascular status if you think you need to. These are wish lists, so you have to see the location because you can get lipoma in any. And then examine the rest of the bodies and take a history from the lump. Okay, come, spot diagnosis. Let's move on. What's your name? Audrey? Diagnosis? Okay, why? Okay, you can't feel, you don't have the, I tell you it's soft, right? It's not attached to skin. So lipoma. Okay, first I just want to see when you look at a patient, you roughly need to know what you're going to say. Short case is like this, it's spot diagnosis and you need to articulate what you're going to, you need to think of what you're going to say. But yes, lipoma, big at the back. It can't, usually sebaceous cysts won't grow to so big. Back lipomas can grow such size. I don't see any punctum. There's no overlying skin changes. This one I can pinch the skin over it and it's mobile, slip sign. So these are the things you need to say. Even before I touch the patient, I'm already going to just show it and then articulate it. Next. Okay, why? Okay, easy lah. Punctum, small, now fixed to skin, attached to the skin. So actually it's attached to the skin. Alright, getting a bit harder. Stay on Audrey. Pressure cookers. Dermoid. Why? Because he said so. Now, why is it dermoid? Okay, good. Location. Can it be lipoma? Can it be sebaceous cyst? Possible, but why do you say dermoid? Because it's the next picture. But you're spot on. But then you know the questions when you see this straight away I need to think, what are the next questions he's going to ask? What are the types of dermoid cysts you have? Entering black hole. You did well to get differential, but you know you won't last investigation and management. That's okay, it's fine. If you say dermoid, you're going to score the marks for clinical and your differential. Don't forget differentials, you need to score the marks. Alright, then you lock in those marks and you move on to your. But dermoid, right? You're right. It's either acquired or congenital. What do you think this one is? Congenital. Because?
Young child.
Huh? Young child. Okay, not too bad. Any more? No scars. Okay, plus minus. Why do you say that? Because acquired? Excellent. So implantation. So acquired are usually because of injury. I implant epidermis deeper. You can get a dermoid cyst. Usually happens at an older age group. Alright? But it doesn't preclude younger people from getting it. But yes, congenital usually occur in the lines of fusion. So there are very classic locations for dermoid cysts in a child. Like your lateral third of your eyebrow, your midline. So fusion lines, alright? Midline near your nasal canal. The nose bridge. Alright? You will not get a dermoid cyst in exams, I can tell you. Very rarely. I'm just showing it as one of the differential. Last one. BCC. Wow, straight away. Good. Why? Pearly Wurler ages. Some more?
Central necrosis.
Central necrosis. Some more? The pearly white is actually around here. Some more?
Irregular surface.
Okay, good. Irregular.
Then age is rolled up. Then
There's a little bit of variegated appearance here. There's a bit of difference. So malignant skin lesions is one of those black hole territories when I was a student. So because it's not taught very much, your only exposure in medical school is National Skin Center. Your derm posting, 2 weeks. You're not going to remember. So, but you need to know 3 cancers, alright? SCC, BCC, melanoma. Just know these 3. The rest of them, it will never come out in your GS exam. In fact, you're already quite sway if you get a malignant skin lesion, but all they want to test you is how you describe it, whether you think it's malignant. Those who say benign differentials, you're not going to score as well as those who really say it's malignant. You score even more if you can tell me differentiate between SCC or BCC. They'll give quite obvious ones. And melanoma. Melanoma are just very dark black satellite nodules. SCC usually more exuberant, exophytic. Whereas BCC is very classic features, pearly, shiny, rolled up edges, right? Okay, any question? The skin is quite straightforward. Just know a bit about the complications, if it's infection, recurrence. For lipoma, the other question they may ask you is there any malignant potential for lipoma? Answer is yes, liposarcoma. But which lipomas are you a bit more afraid or suspicious that it might have malignant potential? Okay, a bit unfair question. But if you know, then you'll score 9 and 10. These are the kind of marks, when I say 9 and 10, it's okay, just give. You're going to pass. If you're scoring, aiming for these lists and distinction, yes, go for it. But that being said, sometimes when you can, just go for the 9 and 10 because you need to buffer for the cases you're going to get 5 or 6. Not every single case you're going to score them well. So you must understand that short cases like that is bam, bam, bam. It's a series of short cases at a go. First case, you feel high, you did so well, you went to management. The next case, I'm struggling with my differential. The guy is hamtaming you for your clinical examination. You can't even reach investigation, the bell ring. You feel that you've got 5. So you need to be ready, mentally ready for that kind of thing. Those kind of bell rings stop you on your track, you haven't reached investigation because you're just struggling in the front part. So that's what I mean by buffer, because you look at the overall, you need to be ready for. Okay, but anyway, the answer to that question, sorry, I digress. Extremities, which are large subfascial lipomas, that means under the fascia of your muscles. Retroperitoneal, alright, these are more, so you're not going to palpate them. Usually it's, you need to scan them and see. Liposarcoma. Okay, thyroid, okay, Bobby. I need you now. Alright, we move on to thyroid exam. Okay, thyroid, must drink water. Alright, so when you walk into the room, if I see a piece of paper here and a glass of water there, I don't even need to touch the patient, I know it's a thyroid. Okay, but then they won't trick you, right? They won't put it there, that actually it's not thyroid, it's some cervical. Okay, so generally, okay, I think I just remove the mask. So, greet the patient. Hi sir, what's your name? When he talks, actually I'm already listening to hoarseness of voice. Alright, I just want to hear. And I generally just comment on that. So you stand by just looking at the patient and describing anything you see. So there's an obvious mass located in the central aspect of the neck, crossing the midline. Describe any skin changes or scars you may see. Then ask the patient to, then I'll actually say that it's located in the center anterior aspect of the neck, because later on we'll talk about other neck lumps where you talk about anterior triangle, posterior triangle. So this is generally anterior triangle because, it's bilateral anterior triangle lah. So it's the center of the neck. You just need to mention that. You roughly know it's going to be a thyroid case, so take a sip of water, sir, but hold it in your mouth. No, you need me to, is it okay? Can the rest see? I forget that we have other participants. Okay, hold it in your mouth. Can you swallow for me, sir? Okay, good. So the mass moves on swallowing, so it confirms that it's likely a thyroid. I can also see the inferior border of the thyroid. I just mentioned this, because if you can see the inferior border, it means it's not retrosternal. Okay, it can't be. Then, can you stick out your tongue, sir? So I usually just stabilize his thing. Stick out your tongue. Now, stick it out forward, yes. You want to see whether it's a thyroglossosis, basically. Alright, later I'll show you a picture. Then, now, I move to the back. Now, can you take another sip of water and hold it in your mouth? Don't swallow yet. Then you put your hand down. This is the palpable swallow test. Then you swallow again. You feel it raise, right? Now, what we're going to do, this is the most important part of this front part here is, everyone can do it, but this part is where it differentiates, distinguishes. You got to feel properly. So start in the midline. You notice that my hands are meeting in the midline. And I'll just start with one side first. In my head, I just want to decide, is it diffuse or is it one side? Is it a nodule, one nodule, or is it multiple nodules? And if it's one nodule, I need to also feel to go and talk about my sector, surface, edge. So there's a few things going on in your mind. But the first thing I straight away, actually when I put my hand down, I actually roughly know, is it a diffuse kind or is it just one side? If it's one side, you focus on that side, the nodule. You want to feel properly, okay? Then after that, you move on to the other side. Do the same. Then cervical lymph nodes, alright? That one we'll cover in the later part. Come to the front, there's actually 4 things I do. So I will percuss, alright? Percuss to hear for retrosternal extension, you should hear dullness at the sternal notch. Tracheal deviation, feel for tracheal deviation. This is the way to, you put your 2 fingers on your clavicle head, and then feel for tracheal deviation. Carotid pulse, because if it's very big, it sometimes can occlude or reduce your carotid pulse, and auscultated for hypervascularity. Which lesions are hypervascular? Bobby, oh, hot seat, serious? Huh? Graves, that's right, I just want to hear Graves. Hypervascular, good. Then check the peripheries, right? These are offer, I never ever do it in a surgical exam. I would like to check the examine the extremities to look for, assess the thyroid status. So we're going to do from hands, so stick your hands out. Okay, but I mean this one you need to do for your medical exam. Stick your hands out, look for tremors. Okay, it's tremoring. I mean there's usually a piece of paper. Okay, then you put your hand down. Feel sweaty palms, thyroidectopathy, pulmonary edema. Feel for your heart rate irregularity, tachycardia or bradycardia. And then proximal myopathy. Can you put your hands like that? Resist me. Okay, and your last one, pretibial mixed edema. And finally, your eyes, or your eye signs. Okay, I won't go through it now because it will take too long. Then check BP heart rate, then do a full cardiovascular examination. Okay. So that is your thyroid examination. Alright. Spend the longest time at that part where you're feeling, because that's where the money is. You got to decide, because your differential is all based on whatever you feel. If you say it's diffuse, your differential is totally different from a one-side nodule, right? So spend some time. The longest time should be spent there, okay? Because once you move on, it's very hard to retract back. In your mind, you have to commit to a differential already. So spend time. Okay, what am I going to say? I'm going to commit to a diffuse, or I'm going to commit to unilateral, or a multinodular, but there's a dominant nodule. So you got to straight away in your mind think, what am I going to say at that point already? Because don't come to the last part, oh shucks, I'm not sure then you just hum something. I mean you can lah. Alright. So like I said, look for the card, look for the paper, don't miss the scar. Sometimes the scar is extremely well concealed. Or, wow, this one is a bit unfair, they go by MIVET, I mean the minimally invasive. I think very unlikely, you're going to see an obvious scar. Palpate the thyroid I went through, look for inferior border. Don't think of thyroid masses only. Okay. That point is for this case. So this gentleman came to clinic with this. I didn't think it was a thyroid. Now why? I straight away saw it, I said, unlikely a thyroid. Even though it's actually in the anterior triangle. But where's the location? It's a bit more lateral. Thyroids usually generally start, like I told you, midline. It's a midline structure, so it usually grows. Even if it's a dominant nodule at this side, possible, but it is pretty close to your angle of your jaw, and it's a bit lateral. And this guy is a guy, male. I mean, not that it's uncommon, but more common in women. But so you start to think of other differentials. Now, what differential is there for this? Okay, thyroid being one, lymph nodes. After you exhaust that one, this is where it gets hard. Don't worry, everyone will say this first too. Any more? Salivary gland what? Parotid. Is it parotid? Submandibular? Submandibular is here, no? It's a bit far. How many of you actually palpated a submandibular gland before? Never, right? How many actually palpated a parotid? Also not many. It's very rare. Trust me, I mean, I know lah, I was a student. Huh? Branchial cyst, reasonable. Okay, so this guy actually had a branchial cyst. Right? So that is your differentials. We'll come to that in the head and neck. This gentleman, I took this when I was at MO. I still kept this photo till now. He has what? Wow, so nice, right? You get this guy. Last time, a few years ago, I used to say, wow, you already know your diagnosis. You see this man in the exams. They always ask him to come back for exam. But anyway, it's been operated already, so don't worry. You won't see this mess anymore. So anyway, yeah, very classic thyroglossal cyst. Surgery to do for this? Cyst shrunk, okay. You just need to mention that. Okay. This is the more important part of the lecture. What is your differentials? Like I said, you have to decide, is it diffuse or solitary nodule? The more common case you're going to get is the solitary nodule. The diffuse one is mainly like those endemic goiter. You do have no nodules, just diffusely enlarged, or Graves, or just some form of thyroiditis where you get it. That one's more common in general medicine short case. But GS, you generally get a MNG. The most common is either a multinodular goiter or just a solitary nodule, or thyroid cyst, just enlarge one side. Solitary nodule, what are your differentials? Xing Rong, what's your differential? Dominant nodule of MNG, number 1. Thyroid cyst, number 2. Solitary thyroid nodule, okay, which is a what? Thyroid adenoma, okay. Thyroid nodule, you know, is a nodule, but more specifically, an adenoma. Yes, all hard, firm things should be CA. You should be in differentials. But what type of CA? There's only 4 kinds of CA in thyroid. It can't be an anaplastic. Okay, anaplastic is usually diffuse. Okay, that's the only thing. Medullary usually is also diffuse. The papillary and the follicular is usually either, it starts with one mass now. Alright, we'll go through the CAs a bit, but yes, these are the differentials for your solitary nodule. How will you investigate this patient? Okay, this is straightforward, I'm just going to give you an answer. TFT, FNAC, ultrasound, and plus minus FNAC. This is standard for the exam cases you're going to see. You will lead you to the question of Bethesda. If you get to Bethesda, that's good because you're moving along in the management. So you do an ultrasound. What is Bethesda actually? Is it an ultrasound? What is actually Bethesda? You all know? Cytological. It's not ultrasonic features, that is thyroids. But you need to know Bethesda, which is your FNAC result. So I FNAC already, which is the... Okay, maybe I will go to Bethesda. So this is, you Google Bethesda, you're going to get this. Basically, the main thing I want to point out about Bethesda is it assesses the risk of malignancy. 1 to 6, there is a risk of malignancy. Actually, this one is not even updated. This was when it was published. Now there's a later one, 2012. Alright? It helps you guide the management. Right? So basically, for category 1 and 2, clinical follow-up, I don't even need to FNA again. I don't even need to offer anything, just surveillance. Atypia, AUS or FLUS, the worst kind we see in the clinic, irritating ones, because this is grade 3, there's actually a 5 to 15% chance of malignancies. You can't just let them go and surveillance. 1 year later, it becomes cancer, you've already missed the boat. You have to repeat the FNA, okay? Or, not wrong to actually even offer resection. Some people offer those which are a bit more high grade, but you don't need to know so much. FN, which is a follicular neoplasm. Now, to take this question even further, if you need to have Bethesda. So now, what Bethesda classification is this? FNAC, convex follicular cells. I go back to this. What classification are we? It is actually a very tricky question. I faced the same problem when I prepared for my past year. It can belong to actually here, no? Or even here. If I was a follicular carcinoma, I could just come back follicular cells also. It may not even show that it's cancer yet, but generally it could be category 2, 3, 4. You have to read the report and see what Bethesda classification the cytopathologist has classified it as. So did he commit it as 3? Did he commit it as 4? Then it will guide your management. Because if it's 3, you actually need to repeat the FNAC, you don't need to lobectomy here. So you got to see carefully. So you got to go back to Bethesda to guide your management. That's my point. But generally, most people will say, differentiate between adenoma and carcinoma. That's good enough. You're going to get your mark. But if you want to score more and go back to Bethesda, you've got to say, I'll read the report more carefully and then see which classification according to the Bethesda to guide my management. Okay, how do you treat MNG? And when to offer surgery? Because MNG is the common one you're going to get. How do you treat it? can conservative, right? So you need to assess actually the thyroid status. Is it hyperfunctioning or hypofunctioning? Is it the hot MNG or the... So if it's hot, sometimes you need to treat them with medication, right? You need to give them refer to endocrine, control the... So if it's recalcitrant, they cannot control. Usually they even go to radioiodine. If fail, still hyperfunctioning, getting a lot of thyroid symptoms, you need to offer, you need to offer surgery, all right? What other indications of surgery are there? Which is the other question you're going to commonly get. Try again.
You get complications.
Compression, that's what I hear. Compression on esophagus, trachea, usually trachea deviation. So compressive symptoms. Anything else? Cosmesis, very good. That's actually one of them. Huge one, disfiguring, they want to take it out, can. Anything else?
Could be suspicious of
Good. So MNG, any of these nodules can evolve to become malignant. Bethesda become 4 or 5 even. Then you have to resect. And when you resect, generally it's a total already. You don't okay lah. There's some indications where there's a majority of the nodules on the right side. You just do the right, because the next question is hemi versus total. I'll skip to it now. Since we're talking about that, how do you decide between a hemi versus total? Because this is if you have really a lot of time, but generally you may not reach here. But it's important because how do we discuss? I don't think I put it. There's a very nice drawing of it, but I didn't put it in this because of it's inside the book. Okay, before we come there, sorry. You need to know a little bit about the ultrasonic features of thyroid malignancy. What features of an ultrasound make it more suspicious to FNA8? That means if they ultrasound already, I told you it's plus minus FNAC. I should have talked about this before I talked about Bethesda. Ultrasound already, you have to decide, should I FNA8? These are the features to suggest should FNA. Now what are they? High suspicion. Can you see microcal, hypoechoic, taller rather than wide? Oh, you can't see. Extension. So it's a extrathyroidal extension, and you see it's okay. Irregular margins. Okay, so these groups you better FNA them. This guy, benign, totally don't even need to touch, and echoic, it's a cyst. Okay, so there is the ATA has graded it accordingly. Okay, so this is actually the main thing I want to point out. You have to weigh a few things. You have to weigh surgical complications versus patient preference. Because if I do a total, what are the cons? I require lifelong, okay, this table is a bit, but I'll try to go through it. I require lifelong thyroxine. You have increased surgical complications because now it's bilateral, there's a risk of bilateral recurrent laryngeal nerve, then you're going to get breathing problems. Okay? So there's always that risk you need to say. However, a total is much more advantageous when you follow up them because now I can use serum TG to do surveillance. I can also offer adjuvant RAI because you can't offer adjuvant if you do a hemi. You lower the risk of recurrence because obviously you've already taken out the side. You eliminate the risk of contralateral or COLT because sometimes multicentric, you don't see it but later on develop. And you don't need to re-op, one op, take it out. But lifelong thyroxine is the main thing. You need to be lifelong medicine. So if they can take that risk, some people say, no, I don't want to be a medicine lifelong, then you do a hemi if they can. Sometimes some certain cancers you can't offer, you have to do a total. But when there's a chance to discuss hemi, there's a chance of recurrence, but it's very rare. You do not require lifelong, that's the main thing. It's the same prognosis, that's why you would offer it. Less surgical complication, only doing one side. And of course, okay, the initial cost is lower. This one is a small point, but they need to surveillance that site forever. Okay? Long-term surveillance of remnant node. And the con is that I cannot offer radioiodine treatment. So you just need to organize your answer to specifically to the patient. You need to discuss with the patient, his patient wishes, whether main thing is lifelong thyroxine, the surgical, whether you can accept the surgical complication and surveillance. These 3 big topics. Okay? Oops. What were my other questions? Sorry. Complications from thyroid malignancies, like I talked about, there's a very nice table in MedBear. I studied the original MedBear, which was Andre Tan's notes. So it morphed to, that table has morphed also, but it's very good. Study that table of papillary, follicular, know a little bit of difference. Know that medullary, the key thing is that you can surveillance them with calcitonin and Mann syndrome. It definitely will come to it if you get the medullary. And anaplastic is very bad because it's usually diffuse and metastatic by the time you see them. Right? It grows very fast. Complications from thyroid surgery. What are they? Going further behind maybe. Never mind lah, we just back the front row lah. Huh? Sorry?
2 H's.
Okay.
Hematoma, hoarseness, hypocalcemia.
Good. Okay. Any more?
Usual complications.
Okay, maybe I'll ask questions. The front row just combine your so it's less stress. 4 must combine. We go row by row. Okay, anyway, yes. So, injury to recurrent laryngeal nerve. You have a chance of hypocalcemia. This is actually usually transient. Why you get hypocalcemia? Because your parathyroid glands are in the way of your total. Sometimes you inadvertently take out or you devascularize. But more often than not, you just devascularize it. They always try to leave the parathyroids behind. But transient, after a while, the vascularization comes back, the calcium normalizes. You just need to support them in the initial post-op period. What's the hematoma? That's the one you really need to know. These are the ones they will test you. Oh, your HO on call. Suddenly post-op after the thyroid, you get one patient whose saturation dropped. You straight away need to think of the thyroid hematoma compressing on your trachea. Your reaction should be, I'll inform my senior, but in the meantime, assess the patient. If he's a surgical airway, I will inform the airway team. Early, supplemental oxygen. Prepare the TNS set to actually cut open the sutures. That's what they want to hear, to relieve the pressure and evacuate the clot. Okay, so you just need to say all these key things. Inform senior, get ready surgical airway team, cut the suture, supplemental oxygen, prepare your adjuncts and maybe NRM, even KIV intubation, that kind of thing. Okay? Okay, Ken. Alright, thyroid. Any questions for thyroid? Actually, there's more to cover, but these are the key things for your short case. Like I said, short case, you can't dwell too deep. Okay, let's move on. Oh, this is my drawing. Okay, I drew this.
Wow.
So, I last time had difficulty trying to understand the difference between paraumbilical versus umbilical. I always thought it's roughly the same, but it's not. So if you notice that umbilical hernia, you're actually everting your cicatrix, which is your umbilical scar. Can you see okay, but the umbilical scar is stretched out. So it's actually everted umbilicus, which leads to this. Whereas in the paraumbilical, there actually is a defect. This here, there's no real defect, it's just stretching out of this. You can push this whole thing back, but technically it's not a defect, it's just stretching out, you understand? Whereas there's actually a hole here, there's a defect in the fascia connecting. The cicatrix, which is your umbilical scar, is actually still present. This was stretched out to become this in the umbilical hernia. You understand? Whereas for a paraumbilical, actually I'm coming at the side of it, but actually it looks pretty much the same. What's the difference though? Clinically, if you can tell me the difference, you already score your marks. Crescent side, okay? So for this fella, I'm pushing the umbilicus to one side, you actually get a slit and you get a crescent. This guy, right, no matter how I look all around, right, there's no crescent because it's just a everted umbilicus. Okay? Right? Just take a note of that. What's this? Umbilical? Umbilical? Agree? Yes, sir. Okay, obviously it's a trick question. So, I put this to show, looks pretty much umbilical in the first picture, I agree. But you pull it around, oh, actually got crescent down here. It's just the skin folded over and cover your crescent. So look for it. Don't get tricked. So this was a parabolic. We operated on this guy as a parabolical hernia. The defect was beside the cicatrix was actually here. Okay? Do you understand the difference now? So don't get tricked. You have to really. This picture demonstrates it very clearly that you need to examine carefully all around. Look for your cicatrix means there's always this depression here. If you do all around for this guy here, you're not going to. It's just like one whole circle is all. There's no cicatrix. I mean, there's no depression. Okay, that's the difference. Okay, how do I examine this guy? So you need to. Okay, I'm going to do it on this thing. You need to stand up the patient. He has really the umbilical hernia there. You talk about skin changes. You talk about whether there's any other scars. Ask him to cough. Same thing. Ask him to cough. You look for visible cough and pulse. Then do a palpable cough and pulse. But once you do palpable, you're committed to do all your feeling maneuvers already. So just say whatever you can see first. Mainly the crescent sign, how big it is, skin changes, and scars. And now I want to push this back gently. Always ask the patient if there's pain because sometimes it's the hole is very small. So push it back. Now what you actually are trying to feel is the defect. Now what I mean by defect is that I want to feel this. You're pushing this back. I want to feel this. Now I want to feel how big this guy is. This distance. Is it 1 finger breath? Is it 2 finger breath? Is it 3 finger breaths? I usually go by finger breaths because you can't really measure it with the ruler. Because your finger is in there, you roughly can feel. 2 finger breaths. What's the implication? If it's smaller, it just means there's a high risk of incarceration, obstruction, strangulation. If my defect is bigger, now I tell you it's a 5 finger breaths. Very unlikely for parameter, but 5 finger breaths, no problem. It can come in and out. The chance of it getting complications is lesser. Okay, that's just all I mean. Sometimes it's very hard to reduce. Don't go and push too hard because you don't want to cause pain. You get negative marks if you cause pain. Okay, other hernias. Okay, sorry. Then the rest of the wish list is just same thing as inguinal hernia. Precipitating factors. Examine the rest of the abdomen for IO and do a PR. This diagnosis, incisional hernia, right? Scar, you can see, scar, overlying thing. The key thing about incisional hernia is that I want you to, if you see incision in there, a guy already coughs, there's a maneuver which I generally do. I lie the patient down and ask him to raise his head so I can see the entire, or ask him to cough. So I usually do 2 things. The patient with the incisional hernia is usually lying down. I always ask him to raise his head above the bed or cough. And cough actually, I do both. So you can see if it's not just, you can see along the entire line. Do I have a picture? Yes, I do have a picture. Oh no, yeah, you see this? Okay. This guy is lying down. You see that there's a huge, this is obviously the hernia. You don't need to, everyone will score this, but the guy who scores the second mark is when he sits up. There's actually an epigastric component. Can you see that? Okay, very vague. This picture is not so. I've got another patient with very, very clear cut. The scars like that. There's 1 hernia here, 1 hernia here. So you pick up the 1 hernia, it's fine. I want you to pick up every single, so it can happen along the entire line. So by asking them to strain and cough, you will detect the rest. This guy is no scars. What's this? AAA? No. What is it? Epigastric hernia, yes. So it's just a ventral or in this region, epigastric hernia. It's just a defect in your linea alba at the epigastric aspect. This guy? Paraumbilical hernia. No. What is it? What am I trying to show? Is there a scar? There's no scar. This guy sits up like that, I already can tell you the diagnosis.
The recti is more.
Recti. You don't get any marks if you tell me recti.
I don't know.
You're almost there. You got the name is divarication of the recti. You're almost, but no sympathy marks. It's all or nothing, okay? Divarication of recti. But yes, this is just a weakening of your linear alba, okay? So basically, is this happening along the entire length of the linear alba? Weakening. So it just comes out, but it's not really a defect per se. It's just weakening. This area now, I can actually measure how big the defect, you actually measure the width of your divarication to see how much the linear alba is stretched. That's usually how we assess whether it needs operation or not. But you don't need to know. This is it's just differentials for you. These are the questions you need to be able to answer. Differential diagnosis. So like, we went through some differentials. If it's at the umbilical, just say paraumbilical. Lipomas, don't forget, skin lesions also can be differentials, but not for those massive ones. It's obviously incisional, there's not much differentials you can give. Okay? Don't give too many. If you think there's not much, then say, like for incisional hernia, it's obviously an incisional hernia. You can say, I would like to make sure there's no underlying mass or complications from the hernia, but there's not much differential. Risk factors to predispose to incisional hernia is very important. You break it up into patient factors, disease factors, and surgeon factors. Okay, it's important. It's not. I mean, you don't say it lah. I mean, although everyone say, oh, they're not say because the surgeon may be offended, but it's important. Surgical factors are important. He may not be the one doing the surgery lah, but you're just saying that surgeon. So, patient factors. Does he strain a lot? Is his occupation requiring him to strain a lot? Right? Does he have diabetes? Does he have immunosuppressed states? Is he on long-term steroids? Is he on TCMs? These must come up, right? Disease factors, like what? So, yes, so disease factors, is the defect huge? What's the contents of the defect? Whether it's a re-op, is it a recurrence, or is it a first time? Habitus, obese, right? These are disease factors. The category of the hernia itself. I mean the characteristics of the hernia. Surgeon factors is how was the op done? Was it done laparoscopic, open? How tight did he close the fascia? Did he use mesh? Technical aspects which you don't need to know so much. Alright, I'll talk a little bit on it, but you don't need to go that far in your MBBS, trust me. How would you repair the hernia? Oh, okay, sorry. Where do you see umbilical hernia in adults? So in adults, actually paraumbilical hernia is the more common one you see. But in which patients do we see the umbilical hernia? Adults. Usually see umbilical hernia in peds, right? When they're born. But which patients? Okay, umbilical hernia more common. Patients with ascites, excellent. So patients with renal or liver failure, ascites, some more. There's only two big groups actually. Pregnant women. No one's pregnant here, but pregnant women. Yes, you can get umbilical hernia. In fact, I think my wife also had an umbilical hernia. But after giving birth, it reduces because the pressure drops. Alright? How would you repair the hernia? So this question actually is talking about whether you do it, the concepts of what choice of surgery you're going to do. Wow, this topic is quite big, but basically whether you do it open or laparoscopic. Okay, maybe this slide will illustrate it a bit better. Generally let's talk about, before I come to this, there's a difference between incisional and paraumbilical. So let's talk about umbilical and paraumbilical first. If we have let's go back. Let's focus on this dude. This guy, we're going to go by the size of the fascia. So you can go clinical, but generally sometimes you do a CT scan to measure it accurately. So now I know that the scan shows that the content is fat, and my defect size is 2 cm. What choice of surgery am I going to do? Open. Okay, yes. So we do open. So then when do we offer lap then? When does the advantage of lap come in? Usually you offer lap above 4 cm. 4 to 10 cm is the perfect category for lap. Because, why can't we do lap for this? Now we're going to do a laparoscopic, I need 3 ports. I need a camera port and 2 working ports. I put a camera port here which is about 12 mm. Then I put 2 more ports for a 2 cm hole. It's a bit overkill and there's a chance of hernia at the new site. So your advantage of lap comes when the hernia is bigger. Not so much for this, but more incisional hernia, where the defect is now 4 to 10 cm. Then anything more than 10 you should do open because it's too big for lap. It's very difficult. Okay? Now less than 4 cm is the decision whether to put mesh or don't put mesh. Oh, I don't have the picture here. Everything is inside. If the size is super small, like 1 to 2 cm, does it make sense to go and, wow, how are you going to put the mesh? So you're putting, okay. I think that concept comes, that's why it's a bit hard to explain. There are a few ways you can put the mesh. I'll come to this slide now. There is, either I put the mesh in between here, which is called inlay. This part, I tell you, absolutely don't need to, if you can't remember anything, you're not going to. What I want you to remember is that if the defect is extremely small, just do a primary. It's a bit overkill to put a mesh. So most people say about up to 2 to 3 cm, you can do it open. Anything more than that, if you're elected to do it, do it primary repair. Anything more than 3 cm, you put a mesh. 2 to 3 cm, anything more than, some people use 2 cm lah, so it varies. It gets even more complex because international guidelines now say anything more than 1 cm, you should just plonk in a mesh because it's better in terms of reducing recurrence. But sometimes it's a bit overkill because the hole is so small, you can just put some sutures and close it. Okay? Then the concept comes into where you put the mesh. You can put it on top, you can put it behind the rectus, or you can put it intraperitoneal. You don't really need to know this part, I think. You just need to know it can place in different levels. Putting a mesh has a higher rate of infection. That is why sometimes you don't want to put a mesh. It's a foreign body. You get mesh infection, wow, you spoiled the whole operation because I got to explant it. So by putting tissue repair, there's no way you're going to get much infection, right? If you just close it primarily. So that's some pros and cons. Costly, not so much. Okay. So I recap again. This part is very important. To decide between open and laparoscopic is by the size of the fascial defect. Of course, patient factors and surgeon factors, whether you can do it lap. But generally, we offer lap for the bigger ones, 4 to 10 cm. For the less than 4 cm category, you plonk in a mesh if it's more than 2 to 3 cm. Okay? If it's very small, we just primarily close. Can understand this? If you say this in exams, generally you will pass already. Okay, you don't need to go into all this. This is for higher level examination, not for MBBS. Okay? Oh, I'm at midpoint, 10 o'clock. 10:30? Oh, okay, that's nice. Okay, we're going to take some questions now. What position would you place the mesh in? Okay, this one is, I don't think you probably need to know that. That is like what I said lah. Inlay, onlay, sublay, IPOM, I don't think you need to know. Okay, any questions from the floor here first, from the previous topics? Yes.
In inguinal examination, you need to find the pubic tubercle when you're standing up to differentiate between the inguinal and femoral hernia.
Okay, his question, I repeat for those who can't hear. He's saying that when the patient is standing up, do I need to locate the pubic tubercle to differentiate between inguinal or femoral? When the patient, at the start, when I'm doing the look part inspection, I already say the mass is, the lump is arising above or below the inguinal ligament. if it's really quite low down, I said it looks to be arising below the inguinal ligament, but I would like to confirm it on palpation of the pubic tubercle. Then you do that. But generally, you don't need to do. I only palpate pubic tubercle when the patient is lying down, because ASIS to pubic tubercle is my inguinal ligament. And I need, actually, that one is more to locate deep ring. Okay? You don't really need to do the differentiating. You can just inspect and see and say. Unless the examiner tells you how do you differentiate the inguinal from femoral, then you go and show those two ways, either above or below inguinal ligament or in relation to your pubic tubercle. Any other questions?
Is there any value for measuring the defect size in the inguinal hernia?
Inguinal hernia.
Yeah, and how do that
Okay.
management?
How do we measure defect size in inguinal hernia? Finger. How you know?
Because
First of all, the first question is, are you able to accurately tell direct from indirect? Sometimes it's very hard. The only way is 100% indirect is if it goes into your scrotum on clinical examination. Other than that, it's very hard to measure defect size. Let me see if I can pull up. Wow. This question needs some nice quotes. I'm sorry. Let's see. I'm going to just show it because I think it's important from a laparoscopic view, your defect size, so you can understand. Can they see the...
You need to share screen.
Huh?
Because this is a Word doc.
So you stop share and share the word.
Share the word.
So we stop.
Stop share.
Let me share screen.
Share screen.
Then we click the. Then we click the word.
Your question on defect size. This is the view from a laparoscopic, my laparoscopic surgery. This is a TEP repair. What you're seeing is a huge defect here. This is your direct hernia defect. This, I just oriented you all. This is the inferior epigastric artery. This is your deep ring where your spermatic cord goes. So this hernia was a direct inguinal hernia. There was no indirect component. How am I going to measure this? You can't. Intra-op, yes, I can. I can measure this by my laparoscopic. This is about 3-4 cm. Actually, this is very big already. It's 4 cm. So we need to cover this. Right? This will manifest as the Hasselbalch triangle hernia you see outside, because the defect is here. Right? This is from inside view. That's why I want to give you this perspective so that you have a little bit of a... Hernia is one thing is that you really need to know your anatomy very well. It took me very long, so I can imagine how it's challenging to understand the concept just by studying it by words in the exams for MBA. But it's fine. Interested, come do surgery. No, actually not. Don't do surgery. So spermatic cord is here. So if I had an indirect sac, the sac will follow, and this actually is the bulge here, right? It's huge because the hernia, the content is going there. So I know that this thing is actually flush to here. It's all flat, and then I have a huge bulge. This is actually containing spermatic cord and your vas deferens, but actually if it has bowel in there, it's going to be huge. You just imagine the circumference of this is going to be. That's how we know if it's an indirect or direct. But this is beyond, you don't need to know. This is, yeah, you go back to that. Any other question? Camera, can you see?
Camera's coming.
Yeah, just come a bit nearer. Okay. So when he's lying down, I feel the ASIS, I feel my pubic tubercle. I put midpoint, 2 finger breaths above. My left hand is actually on the deep ring. This is not reducing, I'm just reducing. So I have a landmark where my left hand should be. Then I take the hernia and, okay, this is provided as inguinal scrotal. Sometimes if it's very small, he lie down, it pops back in already. So it's very easy. You just need a landmark, put your finger right smack on the deep ring. So if the first case happens, that means it really reduces. All you need to do is landmark, find your deep ring, his right side, right? So right hand, right hernia, left hand, left hernia. Okay, if it's a left-sided hernia, then you get him to stand up. Now, the harder one to do is the inguinal scrotal. I've landmarked it and I put my left hand on the deep ring. So I don't need to keep my left hand there. I just need to roughly know where the deep ring hole is. So my left hand is actually creating a funnel here, and I'm actually pushing the inguinal scrotal hernia. and then squeezing it in, and slowly you'll feel the bowel. If it's really bowel, it will just rush through your other hand. You're actually just massaging the contents back into your deep ring. So your left hand actually helps the movement. Your left hand actually massages and squeezes it in, as opposed to just shoving like this. It's not going to go in, right? It's very, very difficult. It is, you will fumble and you'll say it's irreducible. Actually, majority of them can be reduced. It's just a technique of doing it. But it is, no matter how many times I say it, you have to practice it on the, so during your surgical electives, go to day surgery. There will always be some cases which is inguinal scrotal. You got to practice this maneuver. Okay? Those included part, of course, I can show you. I mean, when you all come. Some in clinic, I think I've shown. Yeah. Okay, come. The other question was,
Should we occlude the superficial ring?
you don't need to occlude. You never ever need to occlude the superficial ring because, like I said, you can't identify or landmark the superficial ring accurately. That location of above medial is just aggravation. Okay, you don't need to touch superficial ring in your clinical exams. You just need to identify your deep ring. The other question which may commonly get is what's the difference between mid-inguinal point and midpoint inguinal ligament? This one you must be able to articulate it very well. The next question is, should we touch the hernia if it's just fat contents? My answer to that is you won't know the contents until you operate. Unless you've done an ultrasound before, then you know it's fat. But yes, you still need to operate, even though it's a direct and fat has just gone in. You still need to offer because it's symptomatic. I've had patients which come to me that patient which was a 4 cm defect, huge, very uncomfortable, very painful because it's tugging on the area. So you have to repair it, put a mesh. Okay, even though it's just fat, because it can be symptomatic. But yes, you are right. They will not ever be obstructed because it's fat only. But it's the symptoms more so.
The last question was the position that you put the mesh.
Okay, so the position is this question. Okay, this picture may be a bit better. Okay. So if you look at the picture on the left, the question is where we should be placing the mesh. So there's overlay. Actually, these terms are not right, so that's why I don't Google sometimes. There's sublay and IPOM. Okay, this one is correct. So this is actually not. I mean, there are a few terms. That's why I don't want to confuse you. There are a lot of terms out there which you have to get right. It's onlay, inlay, sublay, IPOM. This one is fine. You can remember this. Sublay is the ultimate. Okay. Inlay is the worst. This is the next best. This is the best. Retrorectus, because you want to put the mesh behind your behind the muscle, so that when you stand up, you have the muscle protecting the mesh. You have less risk of skin infection and wound infection if you put it too high. However, to get into this plane is the holy grail. It's very hard to do sometimes in the operation because it's all stuck down, especially in incisional hernia. It's sometimes impossible to get retrorectus. But if you're experienced enough, you can get there. The alternative, if you do IPOM, which is laparoscopic, IPOM only, I mean, it can be done open, but majority of IPOM is from posterior. You see where the mesh sits? It's behind your peritoneum. So you come from inside, you put your mesh inside. So it depends on which approach you use. That's why I said it's a bit complex. All you need to remember is that open versus lap. If I do open, do I put a mesh? That's it for incision hernia. Whether or not you manage paraumbilical, umbilical, incisional hernia, they're all the same concepts for this. I actually wanted to, I know I'm close, I'm supposed to share, I wanted to share a story before you went for break. But it's just for entertainment. This one has no learning value whatsoever. I'm sure some of you have heard this story. I always share this story because to me it's still my most epic. So this guy is a 50-year-old gentleman. He ate nasi lemak. Okay, for those who have heard it, just enjoy the story again. He ate nasi lemak and he said he got something stuck in his throat. So we had to do a scope for him. So when I did a scope, this was the first thing I said, you eat nasi lemak, what can it be? Actually, we did a CT scan and they showed a foreign body there. And I was like, wow, what else what could you have eaten? So he ate this, and we saw this in his esophagus. We're now in the esophagus. So any guess? Squid, yes, okay. So you see tentacles, these are tentacles, by the way. So we were like, what the hell is happening, man? So I actually had a better view when I lifted all the tentacles nicely. And then I actually saw there's a beak, because my scope was actually scraping something hard. But it's actually the beak. If you notice, there's a beak here. If you didn't know, the octopus mouth has a beak, a very sharp beak. So they were like, wow, jialat, what do we do? So I started tugging on some tentacles, but we broke off 2 tentacles. Then my friend said, don't try, you have only 6 more. We couldn't, so it's stuck in the thing, right? It was lodged in the CEJ, which is your cardioesophageal junction. So moving up and down. Actually, I have a video, but I can't put it up here. So my consultant said, that time I was an R5 resident, 5th year. I said, I have this problem, I can't do anything. He said, do you counsel for thoracotomy? And I was like, wow, no. I didn't expect an octopus into this. Then he said, okay, wake up the patient, we'll do it tomorrow, we'll talk to him properly. I was like, wow, that's quite严重, man. You've got to do almost an Ivor Lewis level kind of operation to remove this octopus. So I changed to a smaller scope. I tried something different. I squeezed it past the side. Then I retroflex. Then retroflex means I turned it around, I saw the head of the octopus. So I don't have a picture of that, I should have taken. So I used my forceps and grabbed the head now, because there's more friction with the head. And we wiggled it into the stomach. And we buried it in the stomach. Actually, this is extremely huge. So this is from fundus all the way to mid. That is damn long. Okay? You imagine it's about 10 cm long. We didn't take it out. We left it in there to digest. Okay, so this is just one of those epic walao. I got a lot out of this, not just the surgical experience, because I called my client and said we managed to solve the problem. But I was quite happy. But anyway, I managed to present. So I flew to the States to present this at SAGES conference. It's a free trip, so one free trip, you get 1 publication. Wow. That's 1 years ago. So this was published in a quite high impact journal, I think 8 or 9. Impact factor, pretty high, but it's just 1 picture. It's the same 2 pictures we took. Okay, but anyway, so you'll go through some stories to tell. There are more, don't worry, I'll tell you more. I'm a foreign body expert in KTPH. I've removed a lot of foreign bodies. Anyway, I'll share more. Okay, anyway, back to the tutorial proper. We'll go on to arterial. Juning, Bobby. Okay, so we'll start off with actually I should put some pictures, but never mind. Okay, so arterial and venous are very visual and very descriptive. In fact, 80% of them are all on the inspection part. So for arterial, right, go straight for talking about, expose first of course, both legs. Talk about, this is simulated, I can't talk through, but you're looking for patches of gangrene, you're looking for ulcers, you're looking for amputations. Alright, so skin, trophic changes, ulcers, gangrene, and even scars. I'll come to scars in a bit. I've got some photos on scars, like your femoral bypass scars and your. So talk about one thing at a time. If there's an obvious ulcer, go for the ulcer first. Right? There's a obvious ulcer located where, and describe the ulcer. The ulcer, I also have an acronym to what do you call it? Describe the ulcer, which is BEDD, bed, base, edge, depth, and discharge. All right. So I go systematically. The base is shallow. It is granulating. The edge is punched out, irregular, sloping, right? It has to describe an ulcer. There are classic features for venous, arterial, and neuropathic ulcers. Depth. Can I see bone? Can I see tendon? Can I see muscle? Discharge. Is it purulent discharge? Is it serous discharge? Is it bloody discharge? So go through these steps for arterial. If it's an arterial ulcer, it's going to be punched out. Generally, it's going to be sometimes deep and gangrenous and sloughy, necrotic. Right? These terms should come up. Just describe what you see. There's no classic. You have to see it and describe it. Then talk about, okay, this is where actually you can actually feel when you're doing the inspection, right? I personally, if he's, okay, actually sometimes he's lying down, okay. Then you lie the patient down. Maybe your head here. Personally, at this point, I'll touch the patient to look in between the toe wet spaces, even though it's under feel part. You can just go ahead, because you're inspecting, I want to make sure that every single toe wet space I don't miss. And also I look under the heel area, especially if it's against a bed, right? You don't see. There's one small ischemic ulcer here, you're going to miss it. So lift the toes, look for in between the toes, look under the heels, okay? And inspect properly. Then this part, talk about trophic changes, loss of hair, shiny skin, and any DM dermopathy, if you can see. Okay. Then now you move on to feeling, right? It's lying down already. I generally start from distal and move proximal. Check for any temperature differences, any tenderness if there's cellulitis. More importantly, you're moving on to cap refill. So you press I'm sure you know how to do cap refill. Press the nail pulp and then look for the refill. It should be less than 2 seconds. Now, this is where you palpate the pulses. Dorsalis pedis, you need to landmark it in between your two malleoli, the midpoint, 1/3, 2/3 distance from your first web space, usually a 2/3 distance down, or 1/3, 2/3. You'll feel the pulse. Actually, 1/3 down, sorry. You feel the pulse. I can feel his already here. Then, posterior tibial, from your base of your heel to the medial malleoli, midpoint, just behind your medial malleoli, you should be able to feel the pulse. You can feel it, it's 2+ already. If you can't feel, I personally do one at a time lah. Some people say do 2 and compare, you can, but sometimes your focus is very difficult to feel, especially those which is 1+. You really need to feel properly. The other trick is that if you press too hard, right, you're actually feeling your own pulsation. Then you say, oh, 2+. Actually, wrong finding already. That guy has no pulses. So just press enough, and I always just press it enough and I let go lightly, and you should be able to just superficially add a little pressure, you should be able to feel it. For those which are bounding pulses. To do a posterior, popliteal, you bend your knee, okay, and then ask him to relax his knee, and then your 2 hands got to dig into you feel your heads of your hamstrings, stay in between in the midline, and then press upwards. Actually, the more relaxed, don't angle it too much. I usually angle it at 45, and just ask him to relax. Yeah, he's not able to do that. Yeah, and you can feel so dig in the midline, you can actually feel the pulsation. Don't press too hard again, same thing. And then finally end off with the femoral, which you locate in now it's ASIS and pubic symphysis. The only difference is right smack in the pubic symphysis. Midline is your femoral artery. Okay, can. And after you do that, okay, I wrote there start from proximal to distal. In your exams, just start from distal to proximal. In FRCS, we always went from top down because you want to see how to compare your the obstruction usually starts from more proximal to distal. So anyway, it's different, but just start from distal to proximal is fine. And then offer a Burgess test. How do we do Burgess test? Same thing. Now this patient is lying. I usually lie him on the side. Imagine the railing of the bed is here. I lie him on the side line him near to where he's going to get up, or just dangle his legs, right? So you can raise both feet at a time to compare any differences. So you raise and look for the angle which one foot becomes paler, right? The first sign is that it becomes pale. That's your Burgess angle, right? Then next thing is that I will ask him, can you get up, sir? So you have to practice this move. Later on, I'll need you to sit up. When I tell you to sit up, you sit up and then you move your legs just like that. So you sit back a bit. So it's halfway so that you can see on the underside, right? So same thing, okay, just imagine I'm lifting up. Now I bring him to this position and I just look and observe for any hyper feeling. It usually become purple or even a bluish color. That's the vasodilation part of your Burgess test, okay? Okay, can. Then you examine the abdomen. Oh, no wonder. It's breathless again. Okay, asphyxiating myself. So, abdomen part for AAA and your femoral pulses, and looking for any obvious masses which can compress, but very rare. It's mainly AAA. Examine the rest of the arterial system. Check your heart, check your carotids. Okay, measure ABPI, and do a dot tone, which is this. you can offer to do this. This is an audible thing. You actually just put it on the same, but you must locate the pulses and do this. This one is an audible. You're hearing the pulses more so than the feeling it. Okay, these are your bypass scars, which I talked about. If you look at the abdomen, your access to your aorta is either by a midline laparotomy or sometimes a rooftop. Oblique scars rarely used nowadays, but sometimes you access the iliac. But the more common ones to access femorals, like the fem bypass, you're going to see two vertical scars here. Okay, next few pictures, I want to stress again, please do not share these pictures, or these are pictures just don't screenshot or share these pictures with people. I can get into trouble because these are my own. I drew this out. So your axillofem bypass is something you don't see very often in the wards. It's basically a bypass from axilla all the way to your iliac arteries, or even distal to your femoral arteries. But your femoral arteries, it goes distal a bit. You'll see two scars here, which are two vertical. It's a bit faint in this picture. There's one scar here, and there's a horizontal scar here. Sometimes you'll see another intervening scar here because they need to tunnel this whole graft from here all the way to the two femoral arteries. Okay, this is your ilio-bifem bypass. It can be an iliofem, one side only. This is bifem, two sides. This is aorto-bifem. That means from aorta to femoral. Same thing, you need to access your femoral. You'll see a midline scar. Do like that. Okay, from aorta, you're bypassing the blockage. The green thing is your graft, okay? And then finally, your fem-peroneal PTA. That means, fem distal bypass. From femoral to your PTA. You can also join your ATA. I have another picture for that, but you don't need to know. But you just see scars like this. On the contralateral limb, you could see another long scar because that's where they harvest the saphenous vein for your graft. Okay, 1, 2, 3. Right, this you have to access because it's distal to your knee already, below knee bypass. Okay, as opposed to this one didn't have any scars on the limb. Once you see this, you better think of even if you say you don't need to get if you say fem-pop bypass, it's also still correct. Or just say some form of bypass, arterial bypass. Okay, what is ABPI and how will you perform it? This one is in your books, okay? I'm not going to go through this. Just know how to measure ABPI and articulate it properly. You may know it in your head, but when you say it, you're current couple. So practice how you say what is ABPI, how will you perform it, what are the values of ABPI. Different values indicate critical limb ischemia or claudication. How would you differentiate arterial ulcer from other ulcers? This one is important. I think I've got a slide on this. This is actually, this is from a book, so it's fine. Another book is not. So you have venous ischemic. Go by the common things, your site, your shape, size, age, base, surrounding skin, temperature. I am sure these are your textbooks, so just remember and know the differences. I don't need to go through this. It's too obvious. Okay, how will you manage the ulcer? Okay, it depends. We're talking about arterial ulcers now. So when you talk about arterial ulcer, you got to manage the ulcer and manage the pathology. Pathology means the arterial pathology because now it's a flow problem which results in poor healing. So how do we manage the ulcer? Take wound swabs, cover antibiotics, make sure there's no underlying osteomyelitis by doing either an X-ray or MRI. Sometimes you may even need MRI to make sure there's no underlying neck fash. If there is, prolonged antibiotics, wound debridements, even amputation sometimes. Okay, that's ulcer management. Of course, wound cover and therapy dressings are. I actually had a question on dressings for my long case for MBBS, so know a little bit about what sort of dressings there are for arterial, especially when you go and do your SIP. Just go to the wound nurse and then ask what sort of the general dressings you can use now. Aquacel, Caltostat, just know a few dressings. Okay, the other part about managing ulcer is that you got to restore the flow. Okay, so how do we restore the flow? you either are going to angioplasty or you do a bypass. Now, how do we decide between angioplasty and bypass? Of course, angioplasty is for more short segment and less distal. What do you call that? Okay, you go by how many percent stenosis. It's either 100% means totally occluded, or 60% stenosis. You can at least pass the wire so you can angioplasty. If it's 100% occlusion and long segment, there's no way you're going to get a wire through to do angioplasty. So those are contraindications to anatomical contraindications to angioplasty. So those are the main things you need to say. Look at the extent of occlusion, look at the location, and also look at the length of the disease. If it precludes angioplasty, then no choice, got to bypass, right? Bypass is a much bigger operation. So just know a little bit of it. There's actually a task classification, but you don't need to know that in exams. It's too much to remember. Okay, how do you manage claudication though? Okay, at the back, how do you manage claudication? I put this question because it's pretty important, I think. Good, lifestyle mod. Okay.
Medications were started on high intensity statin as well as aspirin.
Good. Statins, aspirin, lifestyle modification like diet advice, treat the DM. DM should come into your screen for DM, treat DM. Anything else for claudication?
Oh yeah, to stop smoking.
Stop smoking, good. Pushing you a bit. Most people answer this. More marks are scored in the later part. Do we do surgery for claudication? Some shake their head. Some say yes. This is entering grey zone area. So those which have failed all therapy and very symptomatic, even though the vessels are patent, sometimes surgery is offered, but I would not say this in exam. So try not to mention surgery in exam because it's a bit contentious. MBBS just mention things which are safe. Exercise therapy. So there's those walk diary. I ask them to push a bit more to increase their effort tolerance, to increase or encourage revascularization or collaterals. Okay, exercise therapy. There's a drug called pentoxifylline, which is FDA approved, but it's not used. It's not used in Singapore. Okay, I may be wrong. I'm not doing vascular, but in US they use pentoxifylline. It's a vasodilator to actually help to increase flow to relieve symptoms. But plus minus, that's if they push you and say what drugs can you use. It's actually a phosphodiesterase inhibitor. Your management of CLI is something similar like I talked to you about. So you got to take a history. How do we evaluate the extent of disease? Ultrasound duplex of the arterial system. Okay, ultrasound duplex to map out how extensive your disease is. Sometimes you even need a CT angiogram to see the higher. Your ultrasound can go as much as your femorals. Beyond that, your iliacs and aorta, you need CT already. So you decide whether I need to angioplasty or bypass. Okay, alright. So that's mainly it for CLI. You roughly need to know your diagnostic criteria of CLI. How do we diagnose critical limb ischemia? This one is important. I didn't write it here. You know your diagnostic criteria for CLI? Oh. Anyone? One answer? Okay, pain. More than 2 weeks. Good. Tissue loss. That's all I want to hear. Tissue loss, pain. Is there objective measures?
That one will be objective measures,
ABPI is used. Actually, ABPI plus minus. Most people will use toe pressure and ankle pressure. Alright, there are specific numbers. So, but you can use ABPI also. But I mean, some places don't use ABPI. So, by the guidelines, I think TP and ankle pressure is not wrong. But the main thing I want to hear is pain requiring actually even opioids for more than 2 weeks, and tissue loss, presence of tissue loss, right? It could be gangrene, it could be ulcers, but there must be some form of tissue loss. Okay, good. Venous. Come. Bobby again. Sorry, Bobby is a perpetual SP. Okay, so same thing. I don't have that many pictures in this. I actually have plenty of pictures for venous, but same thing. I also cannot show. Okay, so venous. First thing is stand the patient. The whole examination is done mostly standing up. So imagine all of it is seen. I would look for varicosities. Is it too near?
It's okay.
I'll look for varicosities, obvious venous ulcers, venous changes. So venous is even more inspection than anything, right? So we're going to go through, let's start with varicosities first. You're going to look in the distribution of your long saphenous vein, which starts from your medial malleoli behind, and, here, and then medial aspect of your calf, medial thigh, and ends in your SFJ. So always think of long saphenous from here to SFJ. Then you have to go behind in your lateral aspect to look for this running back and ending in your saphenopopliteal junction. So got to make a show of seeing both and examining. You can't just stand still and just look at both, right? You got to just wayang a bit, right? But look carefully for the distribution because it's what you're going to see. Whether it's one side, both sides involved. Then now we go to the small changes. I think this one you can sit down. You look at the small changes like hyperpigmentation, venous ulcers. Okay, all these are words to you. You got to Google, you got to see the picture so that when the time comes, you know what to say. All right, every single thing needs to be looked at. Even spider reticular veins, go and Google and see what they're like. Usually, old people have these kind of stringy veins. Edema and ulcers, same thing. Describe it as a bed. Where is it located? Gator's area, alright. Gator's area is this medial aspect. However, if you see an ulcer on the lateral aspect, what does it mean? It means the short saphenous vein is involved. Okay. If you think about it, your majority is actually from your long saphenous vein. That's where the distribution, the most pressure is. That's why you get a lot of changes in this area. That's the highest pressure of venous hypertension is there. That's where you get a lot of changes occurring. If you have long-standing inflammation and all that, you're going to get the inverted champagne appearance. Tourniquet. Now what you use, you can actually use your BP tourniquet, or sometimes you have Foley catheter, but I suggest using that BP tourniquet. Just wrap around, click it, tighten it, and then now ask him to stand up. Okay, stand up. So where do I put the tourniquet? Just below, don't go and put it so high. You just want it to below your SFJ. So if it reappears, now all the varicosities reappear, what does it indicate? That the incompetence is below the level of SFJ. If now no varicosities appear, you know that it's at the level of SFJ. Or higher, it could be higher. But I think just say level of SFJ. Repeat the process for putting the thing at the mid-thigh. Now you're testing all the perforators. Mid-thigh, above knee, below knee. You're basically repeating it 3 times. Some people say, put 3 tourniquets. No, no such thing. I won't suggest that. Just got to repeat it again and demonstrate till the level of which you identify the incompetence is. Okay? Perthes test, the same thing. Trendelenburg, even best. You repeat the same thing, put your hand in your SFJ, ask him to stand up. Your hand is simulating your tourniquet. And Perthes test, you put the tourniquet just at above knee, ask him to tiptoe or walk around the room, tiptoe. What you're trying to do is you're squeezing your superficial system so that all the blood now is a test for deep vein incompetence. I repeat, Perthes is a test for deep vein incompetence. If he tiptoes and all the blood goes into your deep vein and it's not flowing to your femoral veins, he will feel a crampy pain in the calves. Alright, so go back and read about Perthes, know how to say it in exams. You can roughly know as a test for, but same thing, you got to articulate it and then say it properly into the exam. Because all this part you're never going to need to demonstrate. It's all verbal. So the faster you can say this with accuracy, the more you can move on. The faster you can move on. Okay, actually this part. Come. Sorry, so many times. So this part is important for you all to understand that there's this test called the stand-up test. we will just simulate it on this SPJ. Turn on. Turn on. Okay, let's see if I can do this. This thing used to be okay. So this is the whoosh test, or rather the audible dot tone. Okay, I managed one. This is quite cool. Okay, so when I squeeze his cuffs, I hear one sound. Okay. If I let go and I hear a second whoosh, it is incompetent. Obviously, Bobby's is competent, very competent. Huh? See? One sound, no sound. One sound, no sound. If I hear one sound and sound again, it is incompetent. You're competent.
Good thing.
Because one student, I think I tried, that was incompetent. I say sorry, go for a vascular checkup. Okay, but anyway, that's your whoosh test. You don't need to demonstrate this, but same thing, you need to articulate it. This is the audible version, but we usually do it at your saphenofemoral junction. But same thing, you squeeze the cuff, you should be able to replicate the test. Okay, this picture shows that there are lots of variations for your long saphenous vein. There's no one variation. The orange depicts incompetence. So you can see that the varicosities appear at different levels. Sometimes it's just distal, isolated varicosities. But the main highway, which is your long saphenous vein, is usually incompetent to give you varicosities. Same with your SPJ, but I want to give you a little bit of knowledge that there are variations in your anatomy where it bypasses your SPJ and goes straight into your femoral. There are variations at the back. Then you see, hey, wow, how come this one's so weird? The varicosity is at the back. It doesn't fit a particular distribution. It's fine. You just need to stick to the roots that if it's a lot of varicosities at the back, I suspect a more short saphenous vein distribution, especially your cuff area, right? This area. But you can also get cuff varicosities more anterior than posterior for your long saphenous vein. But like I said, this is all a variation. Okay, there are some pictures. This is your medial malleoli ulcer, healed ulcer. Very shallow edges, alright, irregular gaiters area. This looks like there's wrinkling here, probably from resolved edema. And there's some granulation here, but it's not obviously infected. Okay, this one, what's happening here? You're worried about malignant change even. Okay, this one wants to show that your Marjolin's ulcer, this one was a Marjolin's ulcer. It turned, they had to biopsy this. Okay. Inverted champagne, your lipodermatosclerosis, but I keep stressing that I usually like to utter the word lipodermatosclerosis until after I palpate, because usually there's a lot of induration there and there's a bit of tenderness, so it should be very hard there, because all from the fibrosis. It's a panniculitis and a fibrosing panniculitis at that, so you should feel a lot of hardness there. So visually, there's inverted champagne. You get ready to palpate and confirm there's lipodermatosclerosis. Okay, classification you know of. CAP, very good. Just need to remember the C. E, etiology, A, anatomy, P, pathology, but you need to know class 1 to class 6. This one you better mark. Because in the exams, I expect you to say, examine already, this is a class what disease. It's all there for you. So you have to examine, see the findings, make sure it's an ulcer, is it healed or is it active? You got to clinically determine that. C5, C6, C4 disease. Okay. And then your management options. Okay, how will you manage this? Same thing, conservative, surgical. If it's conservative, you can do mainly lifestyle modification. So raise the bed, raise the legs above, put 2 pillows when he sleeps, try not to stand too long, advise weight loss, and mainly positional, because a lot of it is because of the pressure. The more you stand, the more pressure there would be. Alright. Surgery. Okay, surgery, it's I didn't put that table. Actually, I have a very nice table. Same thing. Okay. Ultrasound duplex. This is what sorry, I'll jump to investigations. How will you investigate this patient? You would make sure there's no concurrent arterial disease by doing an ABPI. And then I'll proceed to do an ultrasound duplex of the venous system. And this is what we mean when you map it out. Okay, this is just a drawing which the vascular lab does, but they also have the real images, but it will showcase the extent of disease. What I'm looking out for here, is it the long saphenous vein distribution? Is it the short? Is there deep vein involvement? Vein, you always need to think of it as superficial system, perforated system, or deep system. 1, 2, 3. The highway is your deep. Okay, your deep system is your final path, alright, to go back, which is competent in this case. All this is incompetent. And then he had some posterior veins as well. Then based on this, you will decide what sort of surgery to do. Now, if it's superficial system, majority of them, you just need to mention that I'll do a endovascular approach, which is an RFA. There are certain terms like step avulsions, sclerotherapy. Those are for smaller. Okay. So I repeat again, small things like these are your tributaries. To treat tributaries, you can do step avulsions. You can plus minus do sclerotherapy is for reticular veins, even spinal. But the highway, the orange thing, how do we treat this fella? You got to RFA it. So I stick in a catheter, come here, burn this whole thing so that there's no more incompetence in it. The other return will find its way through other tributaries, but I have no more incompetence in this. I have occluded the entire, there's no more pressure within that column, in the hope that you will reduce the hypertension and you will heal the ulcer or the symptoms. Okay, so that's what RFA does. Same way with stripping. If I cannot RFA because this is too curly-wurly, just imagine it's super curly. I can't stick my catheter through. Anatomically, it's very hard to. You need a straight line, or at least to reach here and then burn from here to here. If I can't do that, then you have to do an open procedure where I cut down here and I stick in from the top down this knob to strip the whole long thing from here. Everything has to be above knee. You never ever burn or strip below knee because there's a risk of injury to your what nerve? Sural nerve. Okay, sural nerve injury. You do not strip or you do not RFA below your knee because there's a risk of injury to your sural nerve where you can get muscle weakness. So we generally burn here to here, strip here to here. Then there are tributaries. They said high tie of the tributaries. It just means there are a lot of tributaries coming into here. You have to tie them off individually. That's the open procedure. Okay, you reserve that for those which are anatomically not suitable. How would you offer the other things? So deep vein, imagine if it was deep vein. Can we do anything if the deep venous system is involved? Very hard. Okay, this is contentious area. So what you would say is that these guys need long-term compression. Oh yeah, compression stockings is the other conservative thing I forgot to say. You got to wear graded compression stockings. You can offer them. So for these people with deep vein involvement, you just need to make sure that there's no deep vein thrombosis, DVT. Incompetence doesn't mean it's thrombosed yet. It just means that you have a high risk to get DVT. You need ultrasound and make sure there's no DVT. And wear long-term compression stockings. In higher level centers, sometimes they can do this valve transplant. Alright, they repair the valves, but you don't need to mention that. It's still, I mean, it's not, some people believe it. Even vascular surgeons are divided on this topic, so I need to mention that. That's my last question. Yeah, okay. Complications which may arise. After you RFA, there's a chance that you can get skin thermal injury. You can even injure nerves. You get a lot of edema and then cellulitis. So those are the complications. The worst complication which can happen from RFA is what? I injure my SFA. I go too near and I burn my SFA. You cause incompetence at your or injure your femoral vein. Because femoral vein is deep already. Right? So those are things you have to mention. Okay. Okay. Moving along. What is this spot diagnosis? You're never ever going to get this in MBBS, but it's okay, just for interest's sake. Varicose veins, one side hypertrophy, port wine stains. What syndrome? Klippel Tremonnet syndrome. Okay? Is it Klippel-Feil or Klippel? Okay, I don't know. Klippel Tremonnet syndrome. So this one will come up for FRCS. It won't come up for your case, but anyway, you get varicose veins. You can read about it if you're interested, but don't waste memory space now. Okay, just for interest. Okay, hair and neck lumps. The common hair and neck lump, the most common hair and neck lump you're going to get is a cervical lymph node. It could be in the posterior triangle, it could be the anterior triangle. All you need to know is how to examine it properly. Same thing like any way you approach any lump, site, shape, surface, all that. I am not going to go through, but the peculiar thing about hair and neck is that you need to make sure that you cite if it's anterior triangle or posterior triangle. Okay, the location is really helps in your differentials. So how do we locate anterior triangle? You need to know your landmarks. Your sternocleidomastoid muscle is your landmark. You're differentiating between posterior and anterior. Alright, so this guy, what do you think he has? Okay, it's very hard to say because you can't feel, but differentials should include, this is a different location. So differentials should include things like whether it's solid or cystic, whether it's midline, anterior, posterior triangle, or even within the SCM or SCM tumor, which is very rare. But majority, as long as you mention lymphadenopathy, should be fine. But you have things like carotid tumor, carotid body tumor. You have things like branchial cysts, like we saw in the previous gentleman. You have abscesses, like tubercular abscesses, if it's tender. Pharyngeal pouch, cystic hygroma, you're never ever going to see it's usually in the pediatric age group. Alright. Midline, like I mentioned earlier, is thyroid. Nothing of thyroid. Okay, the wish list for this one is a bit more detailed. You have to examine the face, the scalp for any mitotic lesions like skin cancers or infection. Okay, infection can lead to lymph nodes, so can cancers. That means mets to your lymph nodes. Request for full ENT evaluation, your ear, nose, and throat with a pen endoscopy. Usually the ENT guys will do a pen endoscopy. You know what a pen endoscopy involves? 3 scopes. I mean, you evaluate nasoscopy, laryngoscopy, and also a esophagoscopy to check the upper esophagus. Actually the whole thing for that matter, to look for any potential mets, lymph node mets, because the nodes can be either primary or secondary. Okay? Primary means it's like lymphoma, secondary is spread there, which is you need to know. NPC, the other area, because nasopharyngeal carcinoma is one of those which just gives you a lymph node, but it's actually but you'll only be able to find out on the ENT evaluation. Examine the thyroid, because thyroid also can spread to your lymph nodes. Examine the breast. Examine the rest of your abdomen, looking for the liver, the spleen, because it could be lymphoma. There's a differential. It means it's a primary hematologic problem. And examine the rest of the lymph nodes basins, your axilla, your inguinal region, sometimes your trochlear region also can get lymph nodes, but the common areas is your axilla, your groin. Okay, this part is a bit more. So what are your differentials? I think I went through a few. But same thing, skin. If you're running out of options, your skin lesions can also be differentials. Your lipoma, don't forget your lipoma sebaceous cyst. But in exams, you know you're going to be a lymph node, so you better know all the causes of lymphadenopathy in the cervical region: primary, secondary, infection, autoimmune, HIV, all your leukemias. Alright, your leukemias can also get lymphoma. Not lymphoma, but leukemias also can give you lymphadenopathy. Okay, the histology, of course, you ultrasound it, you do a FNA. If the FNA comes back SCC, what's next? It's a bit unfair, but what should we do? This is a bit more difficult, but so SCC, what I want to hear is that you do a chest X-ray, make sure it's not from the lung also, because sometimes you get SCC lung, can spread to lymph nodes here. Check the whole entire, go through the same thing, the ENT, it could be a SCC of your skin somewhere here. Right? So where areas you can get SCC, you can even get SCC esophagus, spread to your supracleft lymph nodes. Okay? If the histo comes back adenocarcinoma, you're thinking a bit more GI tract. Right? You need to do OGD, you need to do colonoscopy, do CT scan, and find where this adenocarcinoma is from. It can't be a primary adenocarcinoma here. Okay? It's very, very unlikely. And then lymphoma is the other big category. Comes back, Hodgkin's lymphoma, then you've got to hunt down the entire rest of the body, all the lymph nodes you can see where it's, but he needs treatment for lymphoma, which is very different. It's chemotherapy. It's really more for advanced levels, surgical. But know that levels of cervical lymph nodes exist, and which levels to excise is beyond the scope of your MBBS. Okay, so 1, 2, 3, 4, 5, 6. Okay, breast. Wow, this topic is very rarely, the only time you get taught breast is at the breast clinic, and you examine breast in the breast clinic. So you need to know how to examine this properly. Maybe you can't. Maybe I'll show you the steps first before I go into the topic proper. Okay, don't worry, I won't touch you. In case later I get arrested. Okay, so expose properly, sit the patient down. Just imagine this is the bed, alright? It's usually at 45 degrees. Sit her up, and then first thing you do is describe what you can see. Obvious nipple changes like I showed you in the previous photo. Any skin changes like pure orange or distortion. Next step, look for asymmetry in the breast, right? One side bigger than the other. Sometimes it's just slightly more swollen because of a lump. And then the two next maneuvers are important to distinguish or to accentuate the tumor. So press the hands against the hips and tell the patient to push firmly against your hips. You're contracting your pecs. So you're pushing up any deep tumors to be more obvious. Next, put your hands above your head, and this raises lifts the breast so that sometimes, especially the superficial tumors on the tail, can be seen very clearly. Okay, so do that maneuver and examine as the patient is doing it, so you can compare which side is the problem, right? Where you're going to feel. They're not going to tell you where the lesion is. Sometimes it's in MBBS they give you a very clear lesion. In FRCS is such a tiny one, you've got to find it. Okay, and palpate all 4 quadrants. So I do it in a concentric circle. Think of the breast as a clock face. So there are zones to the breast also. So as you palpate, I use my other hand to support the breast and massage inner, outer. Alright, just think of the breast as you got to palpate inner, outer. 1 o'clock, 2 o'clock, 3 o'clock. Come to this side, support. Alright, and then do the entire o'clock. Spend a little bit more time also on the axillary tail. The tail of the breast is where you miss a lot of lesions. Here and down here are the 2 more common areas you miss. So make sure you feel properly, and then don't just palpate one. You have to make sure of palpating inside and on the outer circumference so that you entirely examine the breast. And when you come to this area, spend a bit more time at the tail so you don't miss any. And also retroareola. You have to ask the patient to squeeze the nipple, and also try to feel around the nipple behind for any lump, which could be a retroareola tumor. Okay, when you do the axilla, I usually, you just imagine you're sitting there, a bit easier to see. I sit the patient up to examine the axilla. I don't lie the patient down. There are a few advantages to this. So I relax the patient. Okay, your shoulders relax. Okay, so the patient must be relaxed. If it's on the right hand, the right side, I use my right hand to support this right hand. Okay, so he should be relaxed, alright? It shouldn't be raised, alright? The advantage of now you feel, anterior group, posterior group, medial group, lateral group, and apex. There's 5 groups you need to feel. The advantage is that you can actually feel the posterior one much much more easier than if you lie down, you actually can't access this area as well because it's all pressed down. So this one you have freedom of movement and he's totally relaxed to go and feel all your same thing. Now this side is left hand. Support it here. This side is easier if you're right-handed. You have advantage to palpation. So you got to practice palpating with your left hand for a breast exam. For those who are right-handed, okay, you got to practice both hands. For those who are left-handed, you got to practice this side more because you're actually palpating with your non-dominant hand. Sometimes you may miss small. Just make sure you take your time. If you don't have, then don't have. But they will usually give obvious ones. And then don't forget supraclavicular fossa. Okay, supraclavicular fossa because you can match that as well. And which this is just your areas where you can match to your lung, bone, and your liver. Okay, let's move on. Sorry. I wanted to show this photo. These are some skin changes. These are not normal already. Right? So, and this, look at the nipple, it's actually a bit distorted. You're suspecting what disease? Paget's, very good, right? Paget's. Okay, scars. These are scars you can potentially get post-surgery for breast. What scar is this? Huh? What scar? What scar? I don't know what scar. Lumpectomy, yeah, easy lah, lumpectomy. Okay, sorry, the orientation is, this is the axilla. So what can this be? This could be axillary clearance, could be sentinel lymph node biopsy also. Alright, could be either or. Usually axillary clearance, the scar is longer. Sentinel lymph node, I just need a damn tiny, a 2-3 cm can access. This one, if it's a bit longer, it's think of oh. Why? Oh. Can? Okay. Home front, okay? Can. Think of axillary clearance or sentinel lymph node. This is total mastectomy, or rather, a simple mastectomy, where we did not recon it. If we did a recon, putting implants or a tram, it will look like this now. Okay, so got to see and then just say what you see the scars. Okay, breast, there's actually a lot of breast is my suspect. So actually, there's a lot of research on breast, but for exam purposes, you got to keep it simple, right? Go by how will you evaluate this patient? I'll do a triple assessment. We want to hear the word triple assessment, right? Physical, examination history, imaging, mammogram, ultrasound, plus your core biopsy. Differentials, you need to know your differentials to, so think of it as benign or malignant conditions. Malignant, there's only 4 in, not say, IDC, ILC, LCIS, DCIS, and then your benign fibroadenoma, alright, breast cyst. These are fibrocystic changes. These are things you need to be able to say lah. It's pretty straightforward for differential. Okay, not so much how you perform. FNAC versus core biopsy, which would you do? Back to front row again. What do you do?
FNAC is less invasive, less pain.
Less pain.
Then, but you can.
Which one will you do?
I'll do core biopsy.
Why?
For invasion of the base.
Okay, so look for invasion. So for breast, very few people will do FNA lah. As in you just do core biopsy because we want to look for invasion of the basement membrane to distinguish between DCIS versus cancer. Next advantage, which most people forget. The bigger advantage is that for breast, we are looking for hormone status. Okay, so you have ER, PR, HER2. Breast, you have to think about. I always think of breast as 3 components. One is the breast disease itself. One is axilla disease. The third is your hormone status. Right? ER, PR, HER2. You can, because now we're moving into things like neoadjuvant therapy. So you don't need to know so much. It's quite cheap, but just need to know that hormone status can be determined on core biopsy as opposed to FNA. What are some suspicious features on MMG and ultrasound? Roughly, you need to know. spiculated mass, some calcifications, ultrasound like distortion, hypoechoic. Just know it should be inside your text, but just know a little bit about this. They may show you an X-ray, ask you to describe, so you roughly need to know some features. Okay, you don't need to describe perfect, but you just need to show the main pathology. Okay, surgical options is pretty simple. It's going to be lumpectomy, like I told you. You think of it in breast, axilla, and system. So breast, there's only going to be a lumpectomy. Okay, not only but lumpectomy or total. And if I remove it all, we can do a recon. Okay, the recon part, I don't think you need to know so much. The more important question is when do we do a lumpectomy, and when do we offer? When is it when is it a situation where you can't do a lumpectomy? It means contraindications to lumpectomy, and must do mastectomy. Okay, so you roughly need to know the concepts. Okay, before I jump there, if you do a lumpectomy, what must the patient agree to?
Radiation therapy.
Excellent. So you must agree to RT. Okay, white local excision plus RT. If you don't want to agree to RT, it's also okay, but there's a much higher risk of recurrence. Okay. Lumpectomy, you're removing a square in the area. There's always a risk that margins are involved. There's a risk that you may need a second operation to remove the margins. Lumpectomy also, the advantage is that of course you will maintain your breast still, but you must surveillance that breast also every year. So it's something like thyroid, but a little bit different because you must agree to RT. Okay, if I do a mastectomy, I don't need to do RT. Okay, plus minus some certain tumors you need post mastectomy RT, but generally you don't. Okay, you don't need to surveillance. You just need to do clinical surveillance because you just nothing to mammogram or ultrasound. You just need to make sure there's no lumps felt. And the size and the disease factor will help to determine whether or not it's a mastect or lumpectomy. Okay, so disease factors, if the size is too big in relation to the breast, obviously I can't. If it's huge, it's 5 cm. So generally, people take 3 cm as your guide. Anything more than 3, consider mastect. But some people, if it's a big breast, 3 cm is not. So it's also a size ratio. It's possible, but generally 3 cm is a marker. Less than 3 you can unpack, more than 3 you think about mastect unless it's a big breast. Next, if it's multicentric, diffuse DCIS involving more than one quadrant, chances are you're going to need a mastect. Okay? That part is clear. Alright. T4 disease and advanced T3, okay, going into a bit more. You have to mastect. There's no comeback. Unless, okay, that's where we introduce something called neoadjuvant chemotherapy. I start off with a 5 cm tumor, but he has extremely good hormone profile. We give this guy neoadjuvant chemo and plus hormonal therapy. You shrink it down to maybe 2 cm even. You do a lumpec? Yes. You subject. That's the advantage of neoadjuvant. You subject a patient who cannot do lumpec. After that, you can do lumpec. Okay. Now, we talk about axilla. Every cancer, you definitely need to do sentinel lymph node. When do we upfront AC, axillary clearance? When it's a confirmed lymph node. So clinically, you palpate a lymph node, and then you FNA it, and it comes back as, or even you call biopsy it, it comes back as METs. You don't even need your sentinel lymph node. It is those clinically you don't palpate anything, ultrasound doesn't look abnormal, then we do SLNB. How SLNB works is we inject dye, we massage, we take out the first blue lymph node and test it. If it comes back cancer, we do a full axillary clearance. Okay? You always try to avoid axillary clearance because there's always risk of what's the complications of axillary clearance. What nerves? I want to hear 2 nerves only. Long, thoracic, and rest is a whole. What other nerves? Thoracal dorsal, right? So you need to know these nerves. What does it supply? What does it injure? And the biggest one you can injure is your axillary vein itself. Right? You can injure your axillary vein or vascular injuries. Then numbness and swelling. Once you do an axillary clearance, you're going to get lymphedema, risk of lymphedema, and stiffness of your shoulder. So they usually need some PT after the operation. Physio. Okay. The other thing. Okay. Any questions for? Okay. Then the other part about breast is the last part is the systemic. So those usually is adjuvant therapy. After operation, you get your HER2, ER, PR. Then depending on it, if it's hormone status positive, you can give them hormonal therapy. HER2, you can give them Herceptin. Okay, so there are certain. Right. I don't think you need to know so much about what are the indications for post-op chemo adjuvant criteria. Well, in general speaking, anything which is T2 and above. I mean, okay. If there's lymph node involvement, there's actually there's a big indications for chemo. I don't think you need to know so much. Is it inside NetBed? About indications for adjuvant chemo? Is inside. What are the indications?
Stage 3 or looking at
Stage 3? Okay, I better correct. Okay, now I better correct errors. What does it say? Actually, I should go and. Yeah. Stage 3?
or look, as in there's indication in stage 3 or locally advanced or HER2 positive.
This is for indications for chemo.
Yeah. Adjuvant chemo.
Stage 3? Okay, advanced. Okay, I tell you what, let me look at it and I'll send out via a chat the indications. I don't want you all to say this in exam and then the examiner raise eyebrows because it has to be updated. Okay. Remind me of the breast. Because breast, the thing advances very fast. Okay, so parotid. Okay, come, parotid. John, come. Okay, parotid, you'll see a swelling at the angle of the jaw, just like this chap. Okay, raises the earlobes. So you got to say swelling at the angle of the jaw, raises the earlobes. Look for scars. What scar are we looking for? Modified Blair's incision, which is usually done like this. Fixed to the skin. And then, okay, this is palpation. Look for any facial asymmetry, like drooping of his lower jaw, because the facial nerve could be involved in a post-op patient. Or if it's a cancer, it could have invaded into your facial nerve. So look for facial asymmetry. Then after you palpate, so you feel as per any other lump. Now you want to see if it's fixed to the skin, whether there's any skin involvement. So pinch the skin over it. Then ask him to clench his teeth. So clench your teeth. And then I'm trying to move it. When clenching teeth, it's actually clenching his masseter muscles because it's just attached to the. You want to see whether it's attached to the masseter. And then feel for cervical lymph nodes, and then test his facial nerve. So a lot of it is just. There's not much to do actually. A lot to say. So palpate, say properly. I feel the lump and describe the lump properly before you move on to all the testing. Once you move on to cervical lymph nodes, you usually can't go back to feel the lump again. So once you move on to here, the exam is almost finished already. Then after that, go inside and look in the oral cavity. Can you open your mouth? You're looking for straight away the two ducts, your Whartons and Stensons. Stensons is your parotid duct. Opus in your upper second molar. Your Whartons is at your frenulum, just beside your frenulum. So look for discharge, look for any mass there, because it could be stones. Look for discharge and swelling. Bimanually palpate if it's a submandibular, but sometimes you can bimanually palpate your parotid as well. You need to wear a glove and put your one finger in his mouth and the other one on the outside and bimanually palpate. Both floor of mouth and parotid. Uvular deviation, because if you involve your deep lobe of your parotid, you can get uvular deviation on the opposite side. And dentition, because sometimes you get parotitis from poor dentition and gum disease. Okay, can. Alright, perform a full ENT. Okay, so parotid is usually pretty straightforward. You need to see if it's unilateral or bilateral. Usually in exams it's unilateral. you're going to get the benign ones like the pleomorphic adenoma and the Wattins. Okay, these are the ones you're going to get. But you need to know the differentials for bilateral, things like mumps, viral diseases. All right. What would you expect on FNAC? So, like I told you, the first two, which is the pleomorphic and Wattins, are the two most common benign conditions. You need to know a little bit about carcinoma. So what are just name me two common carcinomas in the carotid. Huh? Mucoepidermoid and adenoid cystic. Okay, so just need to know 2 or 3 cancers. The list is actually inside your manual. So just need to know 2 or 3 cancers which are, but the more common ones you're going to get is PA and the Wattins. The other questions you may get is how do you differentiate pleomorphic and Wattins clinically if I don't have any histo? Do you know any features? How? Anyone? Charlotte? Okay, so pleomorphic adenoma, usually it's a bit more firm and hard. It has usually only, it usually is unilateral. Wattins has a chance to be bilateral. In fact, more common than your pleomorphic. But it's not that common, it's only 10 to 20% chance to be bilateral for Wattins. But if you look at both sides, Wattins, yeah, I wouldn't say pleomorphic as my first differential if both sides involved. Wattins, just remember, behaves like a lymph node. It appears really like a lymph node. It's a bit less hard than the pleomorphic. And Wattins appears in smokers and elderly patients. So elderly smoker, you won't know if he smokes a lot, but these are the characteristics if they ask you how do I suspect. Smokers, very, very high chance to get Wattins, and elderly. So Wattins usually occurs in the later 60s, 70s. The earlier 30s to 50s is pleomorphic. But that being said, age is not a very clear distinguishing thing. Some features to suggest malignancy. This one is pretty simple. Facial nerve involvement, skin involvement, muscle involvement, whether there's lymph node involvement. Okay, so clinically these are the things like. What surgery would you perform? There's either going to be a superficial parodidectomy or a total parodidectomy. Total if it involves the deep lobe. Okay. Complications that arise from surgery. This you should know. Parotid surgery complications. Injury to facial nerve should be your number 1. Okay, first thing you utter is injury to facial nerve. Next, bleeding, wound infection. Okay, if you're at a loss, always go back down to the things you can always say for any surgery. Wound infection, scar formation. Okay, but that cause you no marks. Recurrence, alright? The other thing is Frey syndrome. Have you heard of Frey syndrome? No. Sounds familiar. Okay, you need to know how to describe Frey syndrome. It's actually a gustatory sweating. What's the pathology of Frey's? Basically, your auriculotemporal nerve has parasympathetic fibers. Your skin has sympathetic fibers. When there's a mismatch, that means your parasympathetic fibers innervate your skin, you're going to get gustatory sweating. Meaning that when seafood you want to eat, you actually sweat because it's now innervated. Okay, so go and read out about Frey syndrome and know how to say it properly. Oh, okay, another story. No learning value, total interest, total entertainment. What's the FB? Do you all see the FB? This is in him, by the way. What do you think this is? Any guess? Okay, not bad. Good try. This guy came and then say he stuffed something in himself. And then we did a scan and we saw this. Then we were all guessing what it was. All taking bets. But, how was it?
Balloon.
Balloon? What balloon?
Yes, long one.
Radio opaque balloon. Okay, anyway, this was a broomstick handle. Even with the feces. Fortunately for him, this hole, which is like a free hole like this, was at this side. So I could peer and just feel the circumference of this at the tip of my finger. 12 cm length maximum. So I managed to get an artery and just, not artery lah, we use a little wood and I managed to get the bottom and pull it out. If it was anything beyond my finger, how? What do you have to do for him? Stoma. We need to laparotomize him, and we probably have to do a stoma. Or probably resect it, but there are patients which had a stoma done before for a foreign body we couldn't retrieve from the anus. Okay, so stoma is my next topic. Stoma is one of those things which can come out very easily in exams because it's very common in the ward. When you can't find patients, just get one guy with stoma and can test you. So okay, let's very quickly say, so look at the site, whether the mucosa is healthy, whether it's spouted versus flushed, whether it's 1 lumen versus 2 lumen. Okay, I'll pause here for a while. If it's 1 lumen, it is a end stoma. That means there's only 1 lumen. If it's a 2 lumen, it could be a loop or a double barrel. You need to know the significance of 1 versus 2 lumens. Then talk about the contents of the bag. Is it solid feces, liquid feces, or urine? Okay, you could have urine, because if it's an ileal conduit, it's urine. Abdominal scars is very important. The absence and presence of abdominal scars, we'll go through some examples later. It's quite important. And the presence of a stoma key. I'll also show you some photos. Feel the rest of the abdomen, inspect the skin. So you need to remove the entire appliance, look for the skin excoriation around it. Ask the patient to cough, looking for peristomal hernia or prolapse. Look carefully at, once you remove the appliance, actually you need to mention whether there's stenosis, whether there's ischemia of the stoma. Then you do colorectal examination because you want to feel, I wrote there 3 outcomes, but actually it's more complex than this. But you want to feel if there's an anastomotic line, because if I did a low anterior section or ultra low anterior section, you actually can feel the anastomosis. If I did an ultra low anterior section, the automatic stoma which that guy will have is defunctioning ileostomy. So that's why you need your PR, because the scoring the higher marks is actually to figure out why he went for a stoma. The first pass mark is to distinguish what type of stoma: ileostomy, colostomy, loop, double barrel, single. That one will pass you. But to score the higher marks, you need to figure out what's happening. Rectal pouch is for a patient which went for a Hartmann's procedure. Okay, Hartmann's, you're going to get an auto and colostomy. Okay, not and, I mean you just get a colostomy. You could reverse it still. Okay, so you need to know the combinations. If I did not have any anus and went for APR, what's the autostoma? This one is an N colostomy. You're never ever going to reverse this. Okay. Input-output chart. Remove stoma bag, go and see all the things. But you never ever remove the stoma bag in the exams. Right? You won't come to that stage. Do a per stoma. It's just things you see. End stoma, loop stoma, double barrel. Most often is side by side. Sometimes they put it separated, very rarely. Okay. You need to know the difference. Okay, I have a few stoma pictures, not all. This is not the whole realm. I can't show you all. Same thing, please do not share these photos, or this is just for your learning. First case, I'm just going to walk you through because I don't think you have time. Liquid feces, midline scar. These are the same points which I was talking about. You've got to be systematic. Spouted, healthy stoma. What's the diagnosis? It's going to be a ileostomy. It's now, is it a single loop or double loop? You can't really see. But I'll tell you it's a single loop. So it's a N ileostomy. Now, they had a surgery here. What surgery do you think N ileostomy was created for? Just give an example. Huh? proctocolectomy. Reasonable, okay? Can? Next, the location. Location is extremely important. I divide location into 4 quadrants: RF, RHC, LHC, and LIF. Same thing, umbilicus is your level. This is your RF location. 1 lumen, 2 lumens. It is a loop ileostomy. Can it be a loop colostomy? Can it be a double barrel? Okay, so there's a few combinations. You either commit to a loop or double barrel. So now loop, let's stick to loop. Double barrel is extremely rare. Very rarely you're going to get a double barrel in exams. Loop ileostomy. What is it done for? I already gave one example before. It's either a ULA or a low anterior section. We protect the anastomosis with a diverting or defunctioning ileostomy. Can we have a loop colostomy here? Some say yes. Locations thinks of colostomy. This one, N colostomy, or rather it's a single lumen colostomy. So Hartmann's procedure. Check the anus, no anus, APR. There are differentials depending on your PR. That's where your PR differentiates things. Okay, there are a few more combinations that I can't go through. Those are set in my tutorial. I've shown you privileged photos. Okay. How would you classify stomas? We have a few ways. Okay, sorry, I jumped the gun. The indications for stoma creation, you need to know decompression, defunctioning, and sometimes it's just part of the procedure, like APR. Okay? Decompression, defunctioning, protect and distal anastomosis. Sometimes they sound quite similar. Diverting, defunctioning, decompression, but diverting and defunctioning almost the same. Decompression is specifically because there's an obstruction. Okay, so you just got to know. How will you cite the stoma? This one is easy, I'm sure it's in your textbook. Away from bony prominences, away from scars within the rectus sheath, alright? Visible to the patient, not at the belt line. How will you classify stomas? There's a few ways. Ileostomy, colostomy, temporary or permanent, and then whether it's N, loop, or double barrel. So there's a few ways you can classify it. Some complications, you definitely need to know your complications. This one is in your text, I won't need to go through. Differentiating ileostomy from colostomy, like I mentioned, it really boils down to the type of surgery which was done, the location, the content. Okay, location and content of the stoma bag gives you a huge clue already to where it is. In the presence of scar and the PR findings will complete your story. And then a high output stoma. Okay, know how to manage a bit of your high output stoma. Basically, it's electrolyte disturbance correction, giving him some codeine to stop the flow of the thing, bulking up the stool, giving him fibrogel. These are all conservative management. Surgery is your last resort. Scars. Okay, this one I can spend only 5 minutes, very fast. Oh, sorry, I always come to this slide and I forget to change it. This one I took off the internet, so don't worry. Indian clinical knowledge. It's not. But anyway, it's just for fun. But the things you need to know is that cautious incision. Actually, I think I have. Okay. So you need to know your Mercedes-Benz. Okay, more important, not just knowing the scar. That's only one part 1 to your exams. You need to know what type of access it gives you. If I see a Mercedes-Benz, I'm thinking of what operation. There's only a few operations you would do. You're not going to do this for anterior resection. Your access to liver, your access to pancreas, your access to even gastric, sometimes your hiatal, but mainly pancreatic and liver. This one is a reverse L. It's a reverse L incision. Okay, this one has 2 incisions now. One is a midline apotomy and reverse L. But reverse L generally liver, your right lobe of your liver. Okay. Cautious is for gallbladder, lance, and great iron is for appendicectomy. Groin incision. We've got the cut down I showed you previously. Sometimes it's paramedian, so it's not in the midline, it's actually at the side, it's paramedian. In the old patients, sometimes they do paramedian, but hardly do not. These scars, special. What scar is this? This one a bit tricky. This guy went for a colon operation, that's all I could tell you. What scar is this? Excellent. Stoma reversal. What stoma do we reverse? Ileostomy lah. RIF, right? So don't forget you can get stoma reversal scar. This is a ileostomy reversal. This is a Hartmann's reversal. Reversed Hartmann's. Midline got a scar, strange scar here. Got to think of stoma reversal. Okay, abdo exam. Pretty straightforward. Okay, abdo exam. I'm not going to go through it. Done. In GS GenMat abdo exam is. What I want to tell you is that think about the different combinations. This one you won't be able to see the words, but go back and draw out different combinations of scars. I did this for my exit. Draw out the what? Hepatomac got scar, what is my differential? Because you want to go into exams not thinking, you just want to pick up signs and tell the differentials. You don't want to think of this right there and then when you're so stressed. You want to think, oh God, liver is what? To me, is liver and jaundice or not equals what? Liver plus no jaundice is what? Spleen is whether got spleen plus liver, what differential? Or is it just isolated spleen? If it's bilateral, that means hepatosplenomegaly, you got to think of different differentials. Then of course in different areas lah. Epigastric mass, I don't think you're going to get that in your MBBS, but yeah, I got that. This was my exit. It's a peritoneal recurrence from gastric resection, epigastric mass. That one was my toughest one, but ballotable kidneys, sometimes you're going to get in your MBBS. Those polycystic, very easily ballotable. You need to be able to examine that. So think of just draw out your differentials. Okay, scrotal lumps is the last one, I think. Good timing, so you can leave some time for questions. Scrotal, I will just quickly go through very fast. You want to decide whether it's inguinal scrotal or scrotal lesion. It's similar to your inguinal, but focusing more on, now obviously you can get above it and focus more on the characteristics like scars, look at the medium raphe, symmetry, varicocele, because now you can feel a bag of worms. Now you got to really palpate the testes posteriorly, anteriorly. Feel the mass separate, feel the epididymis. So you got to feel on the posterior spermatic cord, feel the epididymis and the vas, feel for lumps there. Feel the other side, transilluminate. The other thing is also examine the penis shaft, make sure you don't miss any lesions on the penis as well. And examine the lymph nodes. Okay, scrotal skin and penis drains into your inguinal lymph nodes, and your testis actually doesn't drain into the inguinal, right? It drains into your parotid, so you need to know that. Different drainage. Swellings, if it's not confined to scrotum, means I can get above it. You're going to think of hernia or hydroceles, infantile hydrocele. If I can get above the mass, you need to see whether is it just the testes or testes plus epididymis. So this is where you need to be a bit more. Like I said, your experience in seeing all this is very minimal. It's when you go to Euro Clinic, you go and palpate, but you just need to know, have a little bit of algorithm, whether it's tender, non-tender, opaque, whether it's separate from the testes, that means it's the mass at the epididymis or not. But generally, straightforward, things being straightforward, the most common exam one you're going to get is just a testicular hydrocele, varicocele, or testicular cancer. You're not going to get the rest. These three, top three. Hydrocele, because very easy, very common. Varicocele, you want to see how you feel the bag of worms. And testicular mass, tumor. It's very hard mass replacing the whole. Okay? So, actually, yes. Not bad. I finished. Okay. I'm going to end off by some tips. Your opening lines are very important. Like I said, go and practice talking. These are all the questions they can potentially ask. Go back and practice and rehearse answering them with each other. How you answer at the first, like I said, practice in a don't beat around the bush, but get straight to the answer, because short case you don't have time. Don't waste your words talking so long. Okay, just get to the answer, move on, next question. Right? Be a bit more chop for short case. Kala Azad, wow, this one my favorite. Okay, what the heck is the Kala Azad trap? So, Kala Azad is one of those things last time as a medical M3. Massive spelling game, what's your differential? I used to like to say Kala Azad. I realized it's a trap. Because tell me about Kala Azad, then you go, I actually can't say much about Kala Azad. So there are certain things in medicine where actually you know roughly what it sounds very impressive, but you can't back it up with your need. I mean, I ask you more, you're going to die. So actually you score negative marks. You know? I'm not very impressed with someone who can tell you Kala Azad, but doesn't even know anything about Kala Azad. Same thing if you tell me, do an iPalm repair. Wow. Or tell me, show this. Good. Tell me what are the 5 steps of show this. You're dead really. You can't back it up. Unless the next higher level is baiting the examiner. It means I actually go and study I know he really is going to ask me what's that. Then you go and study it. You say, well, you just take your time. You already know your ball is in your court. Then you give it to him. But I would say that baiting examiner is a bit dangerous for MBBS. Don't try baiting. But for FRCS, we actually bait. Because I know that this area is my knowledge strength, right? So you always got to hide your deficiencies, got to get the conversation to the areas where the ball is in your court. This one is a skill some people have mastered. Because it's viva, no? It's how your conversation, you want to lead him to the area where you know a lot. See, you know a lot about pleomorphic adenoma. You want to quickly stay on pleomorphic, don't go and ask me about Watkins. So you have to keep the ball in your court. So I usually lay traps for the examiner. Sometimes say, there are different, an example is the lymph nodes, right? There are several lymph node dissections I know of. Then tell me more. Then you elaborate. So these are ways you can lead the conversation into areas where you want them to. But I tell you, in exam setting, you're so damn stressed. You have no time to go and bait. You bait your own self to your death. So don't. Okay, then know when to back down. Sometimes you know that an area is a black hole already. You're entering area where, I sometimes just tell examiner, I'm not too sure. By doing that, you are, number one, okay, you already don't get marks for that, but you are moving on. You're saving time. You know that you're wasting time. Sometimes you can spend 2 minutes just wasting on one question, as opposed to the guy who say, actually, I'm not sure. Then he will try to either help you or ask another question. So you move along in your 8 minutes. You maximize your 8 minutes, as opposed to just trying to salvage that one question. Actually, you don't score any mark at all. And I've seen it a lot of times. I mean, I've been an examiner. Just keep beating around that one, wasting, then ring. Then you actually, I can't. Then we think, what shall we score for management? Just give one. It's like, so you don't score any marks. So just be careful that if you don't know, but don't do that too often also. Not every day, don't. Also, jialat. So know when to use that card carefully for those who really forget it. There's no point. You can't even work from first principles. So if you can answer from first principles, at least you can say something. At least you can talk sense. But if you really can't even say anything, if it's a no all or nothing question, then just say don't know. Okay, what's that? Oh wow, these are more stories. Okay, we're reaching. I mean, this is the end already. So these are more foreign bodies. So this one is easy compared to octopus. Octopus is the highest level already. So other fishbone, lala, shell got stuck in the CUG. Dentures. This one, mushroom we removed from it's a bezoar. This one best. Perforated the door. He swallowed a toothpick. He perforated the duodenum and went into the liver and caused an 8 cm liver abscess. And he comes in, actually he has no pain, he just a little bit. Then we scan, foreign body there. And they went into the... So many interesting cases. This is just foreign body. Okay. This is the end. I told you 4 years ago I started, every year I add one picture of my daughter. So this is now 2020. Okay, any questions? Okay, let's take questions from the floor.
Yeah, so I think for hernia, there's a question. If the hernia does not enter the scrotal sac, Then how do we still palpate for the testes or spermatic cord?
If the hernia doesn't enter the scrotal sac,
Do we still need to palpate for the testes?
of course, yeah, I do all the steps. So I always palpate testes as a show. It's part of your steps, yeah.
Okay. Then the second question is, if we are unable to reduce the hernia, how should we still proceed with the examination?
If the hernia
Cannot be reduced.
cannot be reduced.
How do we continue?
Oh, no need. Okay, if you can't reduce the hernia, just say it's incarcerated, it's irreducible. Then you don't need to go and do that thing about showing him. It's already out already. So you don't need like you just say lemma. Ideally, I would like to reduce to the deep inguinal ring. However, in this case, it's incarcerated. I will not proceed because I don't want to cause discomfort to the patient. Then you move on lah. Then the questions will then it ends there already lah.
Then for thyroid, if we are able to visualize the inferior border of the thyroid, is it still a need to percuss for retrosternal extension?
Good question. No need.
Okay.
Yeah.
Okay. Then for this vascular question, so how does the location of the occlusion determine whether we do an angioplasty or a bypass?
Wow. Okay. So if it's a bit more distal and it's a long segment, sometimes your angioplasty can't reach all the way and reach and access as long, okay, to keep the answer simple, as long as the procedurist can think that they can angioplasty it, because it's dependent on the skill level of the angioplasty. Some distal lesions, some IR people also can angioplasty and balloon it. So I would say location not so much, is the extent of occlusion and the length, which actually helps to decide. The location plus minus, but generally more proximal, you tend to be able to angioplasty. The more distal ones is a bit harder to angioplasty. That's in the really distal below.
Okay, that's all the questions from
Okay.
the home.
Any other questions?
Okay.
Okay.
I think there's one question
Yes.
about, can you repeat the differentials of malignant breast lump and go through the 4 breast scars again on the screen?
Put through the what?
The breast scars
breast scars.
from surgery.
Okay. Lumpectomy,
Okay.
axillary clearance or sentinel lymph node biopsy, simple mastectomy. This is simple mastect plus recon. This one was an implant. Recon, I don't want to go there because you can do implant, you can do autologous tissue. It means you do a flap, which is a tram flap, LD flap, different flaps. You don't need to know. And what kind of cancers are there for malignant breast?
What are the differentials for for a lump that you think is malignant?
Breast.
Yeah.
Okay. What's the most common? IDC, intraductal papillary carcinoma. ILC, intralobular carcinoma. DCIS is also considered invasive. Now, LCIS is the one actually is now classified as benign disease. So it goes. LCIS technically is not considered a cancer. DCIS it is treated like a cancer because the malignant potential is very high, and sometimes you call biopsy, you only see DCIS, but it's harboring, it can be upgraded. So there's a 20 to 30% upgrade to a real cancer. That's why you need to resect it with margins. The difference between, that's why I'm entering more detailed breast. Breast, I can spend one whole lecture talking about breast. LCIS, I just need to resect it. There's a chance of upgrade, but smaller chance, but I do not need margins for LCIS. It's not really, and you don't need to do sentinel lymph node biopsy for LCIS. DCIS, some high-risk DCIS, you may do sentinel lymph node biopsy. If it's high-grade, very large, extensive, you may want to do sentinel lymph node in the first setting. If you're going to, okay, it's confusing you all. If you're going to do a mastectomy, because this guy is 4-quadrant DCIS, for a DCIS, I have to do a sentinel lymph node biopsy if I'm going to do a mastectomy for DCIS. Because if not, you will not be able to access the lymph node status. As opposed to if it's just a simple DCIS, I'm doing a lumpectomy, I don't need to technically do a sentinel lymph node. It's DCIS, it's in situ. Unless it comes back cancer, then you need to go and do a sentinel lymph node to go and stage the, because you did not, I told you to think of it as breast, axilla, and the system. So you did not assess the axilla. I think I'm confusing you all. That's why. Is that clear? Does that answer the question?
Yes.
Okay.
Okay. There's a question for at the same time about breast examination. So, if the patient does not know what you mean by expressing her nipple discharge, do you do it for her?
Yes. You do it. You have to do. You offer to do it and tell the patient, I'm going to do this first. Don't go and do it. Just explain to the patient. Sometimes the examiner say no need, then you move on. Yeah. Especially when you're doing sensitive things like this. But they won't. I usually would explain what I'm going to do. Say, I look at the examiner and say, I would like to actually ask the patient to express. If you can't, I would like to do it. Do I go ahead? Then you say go ahead. Usually they won't. They won't make 20 students do that. Okay? They want you to just feel the lump, move on. Got lymph node or no lymph node. Find you basically need to locate the lump, got lymph node or no lymph node. Okay?
Okay.
Alright. The final thing I want to mention is that those who are okay, this is selling koyok time. Okay, I'm gonna sell some koyok. The whole entire this project started a few years ago. Actually 2 years ago when I exited. I decided that this lecture, there's so much ground I can't cover in 4 hours. But there are a lot of things which I need to draw a table to see. So we actually have the written format of this. It covers so much more ground than what I can cover here. They won't be, unfortunately, out before your MBBS. Sorry to say, but those who are doing advanced surgical examinations, actually there are advanced questions within there to prepare you for MRCS and FRCS at your later. So look out for it because it's really a lot of, I'm not trying to brag, but a lot of people have contributed to this and it's really thankful to all these people. These are all like, to me, the key people in surgery. They all have contributed to this. So hopefully it will be helpful to you all. But no use now. But in future, yes, and maybe your juniors will. Okay, Ken. So any other things I can help you all with? If not, we end here. Okay, to those at home, if you all have any questions to those at home, you can just email or you maybe submit it, either email me directly or you tell your group reps, Ariel and Joshua. Then they can compile, then we can answer. And those who are posted to KTPH in the future, then I'll see you all around. And then I don't need to go through this anymore. We'll just go through long case. Okay, Ken. Yeah. Points, I'll pause here. One of the key points about GS short case is that, no wonder I'm so breathless. Like, why am I out there? Okay, sorry. Goiter or just a solitary nodule or thyroid cyst, just enlarge one side.
You want a Doppler?
Yes. Yes, sir. Thank you.
Make sure you wash your hands.
Yeah. Okay.